the second day of Precision Oncology Unplugged. And with immense pleasure, I would like to invite our program convener, Dr. Sandeep Jasuja, sir, who is Medical Superintendent at State Cancer Institute and Head of the Department of Oncology at SMS Medical College and Hospitals, Jaipur, for the welcome and introductory note. Over to you, sir.
Dear colleague and friends, a very good evening and a warm welcome to day 2 of Precision Oncology Unplugged. And after an intellectual stimulating first day filled with the pioneer discussion on the lung and breast cancer, we now shift our focus to another critical frontiers: gastrointestinal, genitourinary, and hematological malignancies. Today's sessions promise cutting-edge insight from the national leader on the HER2 positive gastric cancer, MSI, RAS targeted therapy in CRC. Also, first-line therapy and strategies in SCC, advanced in GU and hematological oncology, including updates from ASCO, ASH, GI, and GU, and involving paradigms in the DLBC and CML. This day reflect our commitment to pushing boundary and embracing innovation in every subspecialty. I encourage you all to actively participate, question, and connect, because it is through such vibrant discourse that precision oncology evolves from concept to clinic. Let's make today an impactful and inspiring as yesterday as we continue this journey of knowledge and collaboration. With best wishes for another fruitful evening, and I welcome all of you on this day today evening. Thank you very much for being with us.
So, sir, you will invite the chairpersons.
So today our chairperson is Dr. Jitendra Pahaljani, and 1 minute.
Lalit Sharma sir has joined, sir.
Dr. Lalit Sharma, please, over to you. And Dr. Jitendra Pahaljani is also a consultant, senior consultant at LCG, and very good friend of mine. And Dr. Lalit Sharma is in Manipal and is also very good and senior consultant from Jaipur. Over to you, sir.
At the outset, let me thank you, sir, for organizing this yet another academic feast for all of us. So, on the very important second day, the first session, which is going to be on the very important topic of transforming patient outcome in the second line HER2 positive advanced gastric cancer patients, I would like to invite none other than Dr. Rishabh Kothari. He's a consultant medical oncologist at Oncovin Cancer Center, Ahmedabad. So over to you, Dr. Rishabh, for this enlightening presentation.
Thank you, sir, for introduction, and thank you, Sandeep sir, for inviting. Can you please share the slide from your side? Yeah, thank you. So you can move to the next slide. So as we know that now in gastric cancer, HER2, MSI or MMR, PDL1 and Claudin 18 are a very important biomarkers, and it is not behind in when we treat these patients. These biomarkers do guide us for first line and second line treatments. And because of these biomarkers and available treatment, the outcomes have surely improved for the patients. So we would be discussing today almost everything regarding HER2 in gastric cancer. As we all are aware that based on all phase 3 trials, even in first line, the outcome or median overall survival for gastric cancers in all prominent trials was somewhere between 9 to 13 months, be it doublet or be it triplet. Next slide, please. And as I told, now we have multiple biomarkers, and we do change our treatment based on the biomarkers. Yeah, so this is something which I was discussing now. Claudin 18.2, we don't have access to the drug, but there are some clinical trials ongoing even in India. So all these four markers do help our patients also. Next slide, please. So, how do we select our first line treatment? Uh, 5-FU and platinum doublet, most likely FOLFOX is our first treatment of choice in gastric cancer. Uh, Most of the time, they are adenocarcinoma, and this is the treatment of choice. Now, based on HER2 positivity or negativity and PDL1 status, we decide whether to add HER2 targeted agent, trastuzumab, or trastuzumab plus pembrolizumab. And if it is HER2 negative, based on PDL1 status, we decide whether to add some kind of checkpoint inhibitor. And if it is PDL1 negative, uh, we consider adding triplet in some patients. So this is how we decide on our first line treatment. This is an ESMO flowchart. Next slide, please. HER2 positivity has been reported somewhere between 10 to 25% across various study, and the rates are higher in G junction patients. And HER2 positivity is also associated with high PDL1 expression. Next slide, please. So, TOGA study is the first study where we came to know that adding trastuzumab to chemotherapy in first line treatment leads to improvement in overall survival. So it is 11.8 months versus 16 months. And based on this, we knew that HER2 testing and targeting HER2 in first line gastric cancer patients is very important. Next slide, please. And and we have realized that even in patients where we can give checkpoint inhibitor, it helps in HER2 patients only if PDL1 is positive. If patients PDL1 is negative, adding checkpoint inhibitor is not helping. And now we would discuss second line treatment. The flowchart again is based on ESMO guidelines. So for the patients who have received first line HER2 targeted therapy, how to select second line agent. So the issue is that first, once you target HER2 in first line, there are chances that there will be loss of HER2. And even as we all know, most of the tumors are heterogeneous. It is not like whole of the tumor would be HER2 positive. There can be some heterogeneity within the tumors also. Next slide, please. TDXD, not only in breast, but now TDXD is important for in HER2 amplified tumors across all the tumor sites. And gastric cancer and gastroesophageal junction patients are most likely to receive TDXD. So, TDXD is very important. TDXD is very important. TDXD is very important for in HER2 amplified tumors across all the tumor sites. And gastric cancer and gastroesophageal junction patients are most likely to receive TDXD. Am I audible?
Sir,
Hello?
yes, sir, now you are audible. You're audible, sir.
Okay. Okay. So TDXD is very important molecule uh, for HER2 HER2 amplified tumors in gastroesophageal junction. Next slide, please. We have specific destiny trials for this subset. We have three trials available. Destiny Gastric 01, which is a second line trial, uh, where TDXD versus physician's choice of treatment is given. Uh, TDXD dose is different from breast. That is something which is important for physicians. 6.4 milligram per kg. It is a 3 weekly cycle. And physician's choice treatment was irinotecan, which is what we generally use in first line. And patients beyond first line progression. So two or more lines were taken, and here we can see that there is an overall survival benefit in this subset 12.2 versus 8 months. And if you see clinical characteristics, most of the patient have received trastuzumab and taxane uh, in prior lines, and these are HER2 positive, means HER2 3 plus or HER2 2 plus with FISH positivity. Next slide, please. Destiny Gastric 02. This is usage of TDXD in HER2 positive advanced gastric or gastroesophageal junction patient with disease progression on or after a trastuzumab containing regimen. This is data from US and Europe. It is a single arm phase 2 study. Next slide, please. So here again, we can see that there is a response rate of around 42% and median progression free survival of somewhere 8 months. Now we'll discuss Destiny Gastric 03. Here they have tried various combinations in first line treatment. And they have also changed the dose of TDXD. 6.4 milligram per kg also and 5.4 milligram per kg also was tested. So there are multiple subgroups. TDXD with capecitabine, TDXD with capecitabine and pembrolizumab. So there were multiple subgroups which we will see, and around 40 patients were there in most of the subgroups, and we have response rate and PFS data for all of them. So this was based on Destiny 01 and Destiny 02 data where we had data for second line. Now this is largely for first line. Next slide, please. Next slide, please. Hello. Hello. I'm not able to see the slides.
Hello.
Hello.
Sir, wait for 2 minutes. I think so. Yashika ji left the meeting. I think so. Internet issue. We'll call them.
Uh,
Hello. Dr. Rishabh can start his slide from his own end, I think.
I will share slides from my side only.
Sure, please. Go ahead.
Hello, sir.
Yes.
Yeah, wait for
Hello.
2 minutes. She will join. Yashika ji joined the meeting.
Yeah. Meanwhile, I am trying to share from my side. If I can do that, then we will start.
Okay, sir.
So just hold on a second. I'm again presenting your slide. Sir, are you able to see my screen? Dr. Rushabh?
Uh, yeah. Now I am able to see. Yeah. So, in this trial, there were 4 or 5 subsets. First was TDXD alone, 6.4 milligram per kg, TDXD plus 5FU or capecitabine. Third was TDXD plus 5FU plus pembrolizumab. Fourth was TDXD with pembrolizumab. Then TDXD with lower dose, 5.4 milligram per kg, and some was standard of care trastuzumab plus 5FU or capecitabine with cisplatin or oxaliplatin. So this is phase 1b2 trial, and they have around 40 patients in each arm except the control arm or the standard of care arm. Next slide, please. So here we can see that median PFS is around 9 months if TDXD alone is given. It is around 20 months if TDXD is given with 5FU or capecitabine. For TDXD plus pembrolizumab, it is around 8 months. For TDXD plus capecitabine plus pembrolizumab, it is around 10 months. And it is 12 months with standard of care arm. It is not supposed to be compared. Next slide, please. The toxicity part, important points to note are that compared to standard of care arm, all the arms with TDXD had some more toxicity, especially uh, SAEs and grade 3 and more adverse events. But in most of them, it was manageable except the arm where it was TDXD 6.4 milligram per kg with capecitabine and pembrolizumab, where there were higher chances of interstitial lung disease and higher chances of SAE. Around 50% patients had SAE. Surprisingly, when dose of TDXD was decreased from 6.4 milligram per kg to 5.4 milligram per kg, the rate of SAEs came down significantly. Next slide, please. This being a phase 1b2 study, what we can conclude is that first line TDXD combination with 5FU and or pembrolizumab had promising anti-tumor activity even in first line. Uh, Whenever TDXD is given with 5FU and pembrolizumab, dose of TDXD needs to be lower, 5.4 milligram per kg and not 6.4 milligram per kg. And I assume that phase 3 trials in first line are ongoing with this combination, and we may have newer options in near future. Next slide, please. So beyond TDXD, there are couple of molecules which are also being tried in this setting. There is zenidatamab, which is a biparatopic antibody, uh, which is an also anti-HER2 antibody and is showing benefit in second line and beyond for this malignancy. Next slide, please. Yeah, next slide, please. So basically, this is called biparatopic because it binds to two receptors uh, in HER2. So this is the study design where trastuzumab plus chemo versus zenidatamab plus chemo versus zenidatamab plus tislelizumab plus chemo are being compared. Next slide, please. So this is the waterfall plot, and we can see that most of the patients had partial response with this combination. So this is also something which is looked in earlier lines and second line or beyond. Next slide, please. Uh, Third drug which is tried is tucatinib, where tucatinib plus trastuzumab plus Cyramza plus paclitaxel is being tried as second line option. Next slide, please. I think this was the last slide. So basically, as of now, we have trastuzumab plus 5FU platinum plus minus pembrolizumab based on PDL1 status as first line option in HER2 positive patient and TDXD in second line in HER2 positive gastric cancer patients. But it is exciting that TDXD is being tried in first line and also uh, these two molecules being tried in second line for HER2 positive gastric cancer patients. Thank you.
Thank you, sir. Would request the chairperson to invite the next speaker.
Dr. Jiten, could you please take over? Okay, so the next presentation is on optimizing treatment of non-MSI high metastatic colorectal cancer with newer and emerging options. And to deliver this talk, we have none other than Dr. Polami Basu, and he's a consultant medical oncologist at Netaji Subhash Chandra Bose Cancer Hospital, Kolkata. Over to you, Dr. Basu.
Thank you, sir, for giving me this opportunity. Next slide. Next slide. So my talk is on role of therapy for MSS, colorectal metastatic colorectal cancer. So first of all, coming to the incidence, as we all know that colorectal cancer is a leading cause of cancer-related death among men aged 20 to 49 years. So the incidence is increasing day by day. Next slide. So now coming to metastatic colorectal cancer management protocol. Next slide. So whenever a colon cancer patient comes to our OPD, what we usually check whether it is resectable or it is potentially resectable or it is unresectable. Because the entire treatment depends upon the whether it is resectable or not. Next slide. So we all know that if there is any oligometastatic, like if there is only single liver met, we have options of surgical metastatectomy. So if it is means hepatic resection is possible, we all know that we have several trial data which showed that surgical metastatectomy have better overall survival. Next slide. We have other local therapy also. If there is any oligomets, we have options of SBRT, we have hepatic arterial infusion of chemotherapy. So these are the options we have if patient present with oligometastatic disease. Next slide. So now coming to treatment protocol for potentially resectable metastatic colorectal cancer patient. Next slide. So these are the chemotherapy agent which we usually use in our day-to-day practice. We use Folfox or sometimes FOLFIRI-based regime. And if it is means if we use as a pre-operative chemotherapy, sometimes we use targeted therapy also, either anti-EGFR agent like cetuximab or panitumumab, which sometimes increase the PAT-CR rate and sometimes increase the DFS as well as the overall survival. Next slide. So now coming to role of perioperative chemotherapy, we have options of perioperative chemotherapy and we have several advantages of perioperative chemotherapy, like it reduces the treatment of micrometastasis. We can we can know the responsiveness of disease, which is important. So that's why we are using perioperative chemotherapy. And another important is the PAT-CR rate. Whenever we are using perioperative chemo, means in a neoadjuvant setting, we are using chemo, there is more PAT-CR rate. Next slide. So these are about resectable or potentially resectable metastatic colorectal cancer management protocol. Now coming to unresectable disease or stage 4 colorectal cancer management. Next slide. So what we usually do, we do this sort of stage, like these biomarker testing for colorectal cancer is very important because now we have lots of targeted therapy, immunotherapy. So we check MSI, we check HER2/neu testing, BRAF, RAS, RAF, and NTRK testing for colorectal cancer. Next slide. So we have data that if patients have any MSI high metastatic colorectal cancer patient, we have immunotherapy, and there are several trials which showed that if we use pembrolizumab plus pembrolizumab versus chemotherapy for MSI high metastatic colorectal cancer group, there is more overall response rate as well as there is more overall survival. So we can easily say that for MSI high group, we can safely use immunotherapy so that we can increase the overall survival. Next slide. Next slide. So now coming to triplet chemotherapy regime, what we usually use, we have options of FOLFOX, we have options of FOLFIRI, and now we can include targeted therapy also like anti-VEGF. And we all know that if we add triplet regime like FOLFOX plus bevacizumab, there is more response rate. Next slide. Next slide. So we have two options. One is doublet chemotherapy versus triplet chemotherapy, and we know that triplet is always better than doublet. Now coming to first line therapy for right-sided tumor versus left-sided tumor. Next slide. So what we check whether RAS is wild type or not. And we all know that according to data, if RAS is wild type, we can safely use anti-EGFR like panitumumab or cetuximab as a first line setting. Next slide. We have data where we are using anti-VEGF for RAS wild type metastatic colorectal cancer patient, and we showed that if we compare anti-VEGF versus anti-EGFR, there is more overall survival when we use anti-VEGF. Next slide. Next slide. So these are the agent for metastatic colorectal. These are the drug which we usually use for colorectal cancer. Next slide. So now coming to second line therapy for metastatic colorectal cancer patient. Next slide. So these are the gene mutation landscape. What we usually check, as I have already mentioned, like whether it is RAS, RAF wild type or not, whether it is HER2 positive or not. If it is HER2 positive, we have options of anti-HER2 agent like trastuzumab or pertuzumab. If it is RAS wild type, we have options of cetuximab or panitumumab. Even if it is right-sided tumor, we can use anti-VEGF also, and we check KRAS G12C mutation also. Next slide. So now coming to KRAS G12C mutation directed therapy, which is a crystal-1 data which showed that if we use anti-KRAS agent, it increased the overall response rate. The median duration of response was 5.8 months, median PFS was 6.9 months, and the median overall survival was 15.9 months. So these are the targeted agent we have for metastatic colorectal cancer. Next slide. Now coming to anti-BRAF therapy. If patient is BRAF V600E mutation positive, we have options of anti-BRAF agent, and we have Biacon data where we can use that this anti-BRAF agent and we can see that there is more survival benefit. Next slide. Now coming to HER2 targeted therapy. If it is HER2 positive, we have options of trastuzumab, we have options of tucatinib, we have options of lapatinib plus trastuzumab. If we use LAP plus trastu, the overall response rate is 30%, duration of response is 38 months. And if we use dual anti-HER2 agent like trastu part 2, overall response rate is 32, duration of response is 5.9 months. PFS was 2.9 and overall survival was 11.6 months. Next slide. Next slide. Now coming to NTRK gene fusion targeted therapy, we know that we have options of anti-NTRK agent. So if patient is NTRK positive, we have options of NTRK targeted therapy for metastatic colorectal cancer. Next slide. We have anti-RET regime also. If RET fusion is positive, we have options of targeted therapy for metastatic colorectal cancer patient. So selpercatinib is an option if RET is mutation is positive, and in that case, overall response rate was 43.9%. So these are the targeted therapy. which we have for metastatic colorectal cancer patients. Next slide. So now coming to third line therapy for metastatic colorectal cancer. Next slide. So if patient already received FOLFOX FOLFIRI-based regime for a third line setting, we have two options. One is regorafenib. We have options of trifluridine, tipiracilin plus bevacizumab also. Next slide. Next slide. So most important is a oral drug. We can use regorafenib as a dose of 160 mg once daily dose. Even we can reduce the dose of 80 mg once daily dose. So for third line setting, we have this oral therapy like trifluridine, tipiracilin option or regorafenib. Next slide. Now coming to emerging therapy in metastatic colorectal cancer patient. Next slide. So we all know that if MSI is high, we have options of immunotherapy, and there are several trials which showed that if we use immunotherapy for MSI high group, there is more survival benefit. But now for non-MSI high group also, we have options of liver transplantation in liver only metastatic colorectal cancer patient. Next slide. So these are the emerging therapy in non-MSI high metastatic colorectal cancer patient. Next slide. So these are the drug which is botensilimab, which is nothing but an anti-CTLA-4 agent, which we can say that if patient is immunotherapy resistant, we can use this particular drug. If patient is in MSS, means patient is not MSI high metastatic colorectal cancer patient. Next slide. So these are the mechanism of action. So this particular drug is means if it is immunoresistant initially, we can safely use this particular drug. There is more T cell dependent killing, more antibody drug cleaning. So these are the drug which we can use for non-MSI high metastatic colorectal cancer patient. Next slide. So these are the treatment landscape for non-MSI high metastatic colorectal cancer patient. We have options of CAPOX or FOLFOX-based regime according to patient performance status. We can use either doublet agent or triplet agent. If patient progress, we can use our second line therapy. If KRAS is wild type, we can use cetuximab or panitumumab. If it is even we can use anti-VEGF like either ramucirumab or bevacizumab also along with the chemotherapy. And if MSI is high, we have options of immunotherapy, but if MSI is not high, we have this sort of drug. Next slide. So next slide. So what we can say that for colorectal cancer patient, we should check the biomarker testing, and if there is any targetable mutation positive, we should use this anti-target agent plus, and if it is MSI high, we should use this immunotherapy. Thank you.
Thank you, ma'am, for the excellent presentation. Next, I would like to invite Dr. Jitendra Pahaljani, sir, to invite the next speaker. Over to you, sir.
So the next talk is going to be on ASCO GI 2025 update. And to make us versed with these important updates, we have Dr. Professor Atul Sharma. He is a Vice Chairman, Medical Oncology at Max Healthcare, Saket. Over to you, Professor Sharma.
Yeah, good evening, Doctor, and good evening to Dr. Jasuja and all the other available audience participant delegates. So, you want me to present, or I believe presentation is with the organizer. I can do either way.
So you can share your slides also.
All right. So my job is basically what I'm going to do is probably whatever is time allotted or maybe 1-2 minute text or so discuss about the presentation done during ESCO GI with regard to the colorectal cancer. Yeah, I could see that. What happened? Somebody else also has shared, I believe.
Sir, do you want us to share share your
Okay,
slides?
go ahead. Fast. I don't want to eat others' time.
Sir, are you able to see our screen?
No, I don't.
We are presenting the screen. Can you check your network again?
Jessica, even I am not able to see the screen of yours.
Sir, are you able to see now?
No, no one is. Even I am not able to see the screen.
There seems to be some network issue because I'm able to see.
I believe it is visible now.
Yeah, it is.
All right, so we move on to next slide. Probably I just minimize my toolbar. These are the few of the trials which probably I'm going to briefly discuss, which were presented about 2 or 3 months ago. Next one, please. So the first is basically the Alaska trial. Basically, what they wanted to do is whether the giving low dose aspirin will reduce the recurrences rate in the colorectal cancer patient. For the patients who had the PIK3 pathway alteration, these may be the either the mutation or some enhancement. So these were the 3 years result which were presented. Next one. So next one, these are the basis for that. So this was a basically 2x2 factorial trial designed for the patient who had up to 12 weeks after the surgery were randomized into the two groups. Basically, they were divided into either those who had the PIK3 exon 9 and 20, which is usually seen in about 10% of the cases, or those who have some alterations, PIK3R1P10 and other PIK3CA changes, alterations, which is seen in probably 20 to 30% of the cases. These patients were divided into further into either the 160 milligram per day of aspirin for about 3 years versus placebo for 3 years. And the primary outcome which was presented was time to colorectal cancer recurrence in the group A, and there were a couple of other secondary endpoints. Next one, please. So they were they were early stage and locally advanced stages, rectal and colon cancer patients. So was stage 1 rectal cancer were also included, and 50% of the patients who were eligible for adjuvant treatment, and they did receive adjuvant treatment. Next one. So if you see that this thing, the primary endpoint was the colorectal incidence of the colorectal cancer recurrences. you see both the group, whether group A with the PIK3 exon 920 or PIK3R1 and P10 another group, there was a significant reduction in the incidence or recurrence of the colorectal cancer after 3 years and so. So more or less probably you'll see if the recurrence was about 12 in the aspirin group, there were 23 in the PIK3CA exon 920 group in the placebo arm, and similar benefit was also seen in the patients who had other kind of the alterations. Next one. So this was the disease-free survival, and unfortunately, as my understanding goes, the hazard ratio was not in favor. There was no significant improvement in the 3-year disease-free survival between those who received aspirin versus placebo, at least in the patient who had the PIK3C exon 920 group. However, the patient who had other kind of alterations, there was significant improvement in the disease-free survival. Next one, please. So this, there were some signs we have been using aspirin. We also use in the clinical practice. There were 3 patients who had the SAE leading to death in the aspirin arm compared to the 1 patient in the placebo arm. There were increased incidences of late post-op complications, DVT, embolism, and aspirin arm. P-value was not reported. Next one. So if I have to take this trial, if I see whether there is some usefulness comparison to existing data, whatever we have been doing, they are the reports which say that aspirin may be useful. They are the reports which say that probably it may or may not be useful. So there is a biological rationale for that. And somebody asked me is it a new standard of care? Practice changing? I would say this probably need little more data to say that this thing. Because number one, PIK3CA probably at the 1/4 of the patient will have these kind of the mutations or alteration. And more importantly, recently unselected patient, next one. They were the presentation with, next one. They were the presentation which appeared in the Lancet Gastroenterology couple 2 months ago, and we also participated while I was at AIMS and this thing. This trial studied aspirin after completion of a standard adjuvant therapy for colorectal cancer, and this was called a SCOLT adjuvant aspirin trial. And this trial, unfortunately, and the primary endpoint was the disease-free survival. This trial, unfortunately, did not meet its primary endpoint. So I would say that still jury is out, and we need to have more data before we start suggesting or offering aspirin in adjuvant setting. Next one, please. So this was the second important presentation during this ASCO GI. So analysis of the first line encorafenib plus cetuximab plus chemotherapy in BRAF V600E mutant metastatic colorectal cancer. Next one. So next one. So they were the 3 arm, basically one encorafenib cetuximab, other EC plus FOLFOX, and third one was the standard of care, which could be any either EGFR or VEGF inhibitor with or with and choice physician choice of the chemotherapy. The patients were randomized, basically those who had BRAF 600E mutant and with a good performance status 0 or 1. And the primary endpoint was the progression-free survival and overall response by blinded independent central review. And the data which were presented was the EC plus FOLFOX versus standard of the care. This particular time, they did not report data for the EC only. Next one. And as you see this, the alpha, they decided one-sided alpha value of 0.204. And they've decided that oral response by BRC is in the tune of one-sided alpha 0.001, then they will go further. PFS was supposed to be 0.023. Next one. The main important aspect with the response rate or the one of the primary endpoints. You see, one can see easily the response rate in the standard of care arm was 640% compared to 61% responses in the patient who received chemotherapy plus encorafenib and cetuximab combination. And the number of the patient who had duration of response exceeding 1 year was 22% in the investigational arm compared to 11% in the standard of care arm. Next one. These are the survival curves suggesting that the 1 year survival rate were about 80% is a standard experimental arm compared to 60% in the experimental arm. Next one. So one may really ask whether what were the achievement of this particular trial. Personally, I prefer to use this or discuss type 2 combination in case the patient performance status permits that. So these are the various studies which try to address the issue of the first line treatment in BRAF mutant metastatic colorectal cancer. Of course, response rate you can get FOLFOXIRI plus PEV probably can give you about 50% response. PFS about 7 to 8 months compared to 9 to 10 months. OS, probably we don't have the mature data for the breakwater study. Next one. These are some of the side effects which are seen in more than 20% of the population. This nausea, anemia, and this thing. Obviously, these are the agents which may have significant side effects. Next one. So these are the key takeaway points from the breakwater. Breakwater showed the statistically significant, clinically meaningful benefit to response rate for the EC plus FOLFOX as first-line treatment. Data did show a trend for improvement with the combination. Follow-up is ongoing, and this was generally well tolerated. This study supported the idea that EC plus M FOLFOX may be a new standard of care for patient BRAF. Next one. So after the presentation, sometime in February or early March, there was a press release by, I believe this is Pfizer, which says that this encorafenib plus cetuximab with FOLFOX probably produced a statistically significant and clinically meaningful improvement in PFS and OS compared to chemotherapy alone. We don't have a full paper for this press release. Next one. Next one. This was the presentation same day. Next one for this part. Can we move on? So these are the questions which probably I'll ask myself. Number of the percentage of patients who will be able to go for this combination. Whether it is a good idea to have a response rate in metastatic CRC as a primary endpoint when the resection is not the primary idea. And what they presented interim analysis, whether this is really a right way of presentation. And number of these patients probably in my practice, and I'm sure everybody else would see that they are patients who have received FOLFOX in the adjuvant setting, and it becomes difficult to expose them again to oxaliplatin-based chemotherapy because of the fact they may have a pre-existing neuropathy. Next one. Am I audible or this because slides are being moved without me being asking?
So
Hello?
you are audible. You are audible, sir.
Then you
Sir,
need
there might be a network issue on our side. Sorry, I think.
to go back to one or two previous slides.
Okay, just a second. This one?
Yes, previous one. The
This.
other important point is that about 20% of these cases will be MSI high. So these patients are probably everybody would consider these patients for immune checkpoint inhibitor based treatment rather than the BRAF inhibitor. Next one, we can go to the next one. So the second important, this is really a path breaking, I consider checkmate 8HW. Next one. So these are the first results of Nivo plus EV versus Nivo monotherapy for MSI high mismatch MMR or MMR deficient metastatic colorectal cancer. Next one. Again, here there were the three arms, and what was presented were basically the primary endpoint for Nivo versus compared Nivo plus EP arm, and the PFS was the blinded independent central review was the primary endpoint. Here again, they had the co-primary endpoint, Nevo plus EP versus chemo in the first line. We don't know there's no presentation, and Nevo plus EP versus Nevo alone. We move on to these are the patients who had prior chemotherapy also, but they were immunotherapy naive. Next one. So you see that this seems to be very, very impressive data. 3-year survival rates are about 68%, little over two-thirds compared to 50% in the EP Nevo alone. So very significant hazard ratio at 0.62, and the median PFS, if you really see, probably in the Nevo EP combination arm did not reach. This is very, very significant development. And the curve started separating early and flattened nicely compared to the checkmate 177 when there was this thing, crossing of the curve pembro versus chemotherapy. Next one. So, and not only this, that this particular combination helped most of the patient, whether they were the liver metastatic disease, peritoneal metastatic, BRAF mutant, yes and no. And however, personally, I think that the patient who had the history of Lynch syndrome, they did not get as much benefit. Next one. So these are the side effects. Of course, the side effects are little higher in the combination arm. We have experience of EP based combination in the clinical practice and other indications, and we know that. Next one. So these are the side effects of this thing. I can just pass over this. Next one. So what did it say about what half of these patients were the baseline initial presentation? 84% had the deficient MMR confirmed centrally, and first-line therapy was in 57%. RAS mutant 25%. About a quarter of these patients had the BRAF mutations, and 14% in Lynch syndrome. Next one. Increase the oral response rate with combination 71%, 58%, remarkable. Increase all grade immune-related adverse events with combination as we were expecting. Next one. And of course, one may ask whether how does it compare to pembro data 177. And I personally think that because the pembro data, I think it is there. Next one. So if you see the keynote 177 trial design, next one, there were some couple of the points which were probably, there was the early crossover, early progression was seen in the pembro arm, where the possible causes people discussed the tumor mutational burden. Maybe that these were some of these patients did not have MSI high, which was confirmed, if I'm not wrong, 20-25% of the patients centrally we did not confirm the MSI high status, or maybe these were the patients pseudo progression. So I have to choose. Next one. I probably will go with the Nevo EP combination. Next one. We can skip this. Please go on to the next. These are the keynote. Otherwise, the 50% 3-year survival 61% compared to 68%. Next one. So these things I already highlighted. Early progression, some doubt of whether all patients were truly MSI high. Next one. Next. So this is an important study, basically, and randomized double-blind phase 3 study comparing phase 102 versus placebo in patient with molecular residual disease following curative resection of CRC. Altair study. Next. This is a Japanese study, Circulate Japan. What are the inclusion criteria? CRC patients after curative resection might have received prior standard perioperative therapy wherever eligible. Probably, and they were stratified factor for disease-free survival analysis, stage 1, 2. Previous one, please. Yeah, versus 3 or M1 disease, and ctDNA status at 1 month post-operative. What they did was these patients were randomized. Control was the basically not further treatment, and experimental received combination test 1 2. And they were followed up for up to 3 years. ctDNA was done every 2 months for 2 years, and CT scan for every 2 months for about 3 years. Next. And baseline characteristic did show that about quarter of these patients had oligometastatic disease, and whether they had MRD positive, adjuvant or surveillance, and ctDNA positive after 1 month was seen in 53% of the cases. Next one. And if you see the disease-free survival in primary population is stage 4 patients, then you can see these are the patients basically. So all patients, if you include, there were no significant differences whether they got placebo or test 1 or 2. However, for the patient who had the ctDNA positivity and they had the stage 4 disease resected, there was significant improvement in the patient group who received the trifluridine-based chemo tablet. Next one. So the question is basically for the house and others is that do we routinely use ctDNA cis2-3 resected CRC for deciding treatment based on the current data? Personally, I don't think that probably may be the predictive or prognostic. Do we believe it is a prognostic when positive? Possible. Would you, and whether we consider its use in oligometastatic disease? Personally, I think that the patient who haven't had a chemotherapy in the past, I would consider pseudoadjuvant. Next one. So this is the final presentation. Basically, a deeper trial. Next one. This is the combination of folfoxide. Next one, please. Folfoxari plus cetuximab versus folfoxari plus bevacizumab in the mainly left-sided colon cancer, those who had the RAS wild type. Next one. And you see if about 350 patients were randomized between the two arms. Per protocol analysis was 162 in the bevacizumab arm and 159 in the cetuximab arm. Next one. So there was significant improvement in the depth of response or deeper response for folfoxari plus cetuximab, significant p-value, but unfortunately, what was as expected or as supposed to be, there was no major difference in PFN and OS in the two different arms. Difference in PFN and OS is seen when RAS and BRAF wild type tumor were evaluated. It was not statistically different, and there was a weak association, unfortunately, in this trial between depth of response and survival time. Next. You see, these are the PFS with the left side and right side. You see, next one. Right side population was small. These are the OS overall survival in the left-sided folfoxari bev versus folfoxari cetuximab. No major difference. Next one. This again. Next one. No significant. This is the second trial after the triplet, which has failed to show a significant benefit in improvement when the 3-drug combination plus bevacizumab. That was the triplet was folfoxari plus bev versus folfox. There was no significant difference. Next one. So depth of response is definitely good, but whether this is good enough to change our practice, difficult to say. Thank you for patient hearing. I stop here. Might have exceeded my time. Thank you.
Thank you for the excellent talk. And I would request the chairperson to invite the next speaker.
Well, thank you so much for that elaborate talk, sir. And for the next presentation, we have a very dear friend of ours, Dr. Jitendra Peljani. He's an excellent orator and he's a senior consultant medical oncologist at HCG Hospital, Jaipur. And he would be enlightening us on making the right start. That is the first line treatment options in RAS wild type CRC. Over to you, Dr. Jitendra. Dr. Jitendra, can you hear me?
Dr. Jitendra, sir?
I am audible?
Yes.
You are now.
Okay. So thanks, Dr. Lalit, for the introduction and Jasuja sir for the opportunity. Yashika, can you share my slides? So, as you all know, that colorectal cancer is long being divided by left and right. So, my work has been done halfway right, that I have to deal with the right part so that there will be no technical or factual glitches. Still, the jury is still about out that how this difference is coming. But for now, we will be focusing on the right side colorectal cancer, which is a metastatic disease, and on the right side. So first line treatment option we will discuss. Next slide. So the treatment decision in metastatic colorectal cancer, as we all know, that depends on multiple factors: age, comorbidity, the location of the tumor, biomarkers such as NGS, MSI, and patient affordability status. Although the drug cost has come down drastically uh, by the innovator, as well as the generic molecules available. So now probably more patients are able to take this drug. Next slide. So coming to the evaluation of how this treatment has changed in colorectal cancer, July 2022, ISMO working group recommended that EGFR inhibitor can be used in colorectal cancer. In September 2022, it was in the ESMO guidelines of lower GI cancer, and it was adapted in the ESCO guideline in the same year in October, and October as well in SMO as well as ESCO. And now in September 2024, the guidelines are also having the similar EGFR inhibitors uses in colorectal cancer in the right side, wild type, RAS type. And there was a pan-Asian ISMO guidelines which also suggest the use of these EGFR inhibitor. So all the guidelines point towards use of this treatment, but how best we can use this in our practice, we will just dig the data a bit. Next slide. Next slide. So coming to the different phase 3 trials, which showed us the first line anti-EGFR agent plus doublet chemotherapy drug. And here, where the main difference arises between the left side or the right side, the Fire 3 data, the CalGB SOG 80405 study, which were both study of the Arbitex, the Fire 3 used Folfiri, CalGB used Folfiri and Folfox. And the other study was with Paradigm study, which was panitumumab with the Folfox study versus bevacizumab. So both had similar chemotherapy regimen versus the biological agent was used was anti-EGFR versus anti-VEGF. So as we can see that if you use in the selected patient with RAS wild type, the overall response rate was better. Like in Fire 3, it was 79% versus 68%. And there was a gain of 10 months with the EGFR inhibitors. Similar results were shown in the CalGB SOLVE study with 39.3 months versus 32.6 months. And the response rate was also better. Although the hazard ratio was not basically not one less than one, but still the p-value was significant. On the other hand, in the paradigm, we saw that the response rate was slightly better, and there was not that much increased magnitude of benefit, which we were able to see in the panitumumab arm. So, as we can see that there are still many things which we would know, but definitely for now, we can see that RAS wild type patient can receive the left side RAS wild type patient can receive the anti-EGFR agent, which will give them better response rate as well as a prolonged disease progression free survival. Next slide. So here we can see that in Fire 3 and CalGB SWAG, both the curve was almost parallel, bearing the later part of the curve, like most post 6 years or so. But in the paradigm, even in the left-sided RAS tumor, around 2 years, the curve actually crossed over each other, and the crossing over led to the decrease in the significance statistically. Next slide. So continuation of the regimen will be aimed to reduce the toxicity while preserving the efficacy, which is usually supported by international guideline in the stage 4 metastatic disease. So treatment continuations are usually based on de-escalation, like reduce therapy associated side effect, maintain patient quality of life, and preserve the efficacy to attain the maximum DFS. So in 2022, ISMO gave its guidelines that if you have given a oxaliplatin based chemotherapy, then you can use continue with the fluoropyrimidine like capecitabine and bevacizumab. If you used oxaliplatin based chemotherapy plus anti-EGFR, you can continue anti-EGFR with 5-FU based therapy. If you have used FOLFIRI alone as an agent, then probably you can continue only irinotecan until progression of the disease. Next slide. So these are the investigation which phase 2, which involves phase 2 and phase 3 data that investigated the de-escalation maintenance for the treatment with anti-EGFR agent. So there are a study like ARMS, which is a phase 3 study, which had cetuximab along with FOLFIRI versus cetuximab monotherapy in continuation versus the macro 2 study, which was a phase 2 study with cetuximab FOLFOX versus cetuximab monotherapy. Then Sapphire was there, which has panitumumab, Folfox versus panitumumab, and 5-FU based regimen. Valentino again with panitumumab alone versus panitumumab and 5-FU leucovorin, and Panama. So these studies does give our insight. Next slide. So this is the systemic review, which suggests concluded that fluoropyrimidine plus anti-EGFR can be considered as a valuable maintenance option in RAS wild type metastatic colorectal cancer. Uh, and we can use EGFR monotherapy also, especially in the left-sided tumors. Next slide. So anti-epidermal growth factors receptor maintenance therapy, the guideline is that we can use an intermittent NDGFR based upfront strategy, and that can delay the onset of acquired resistant mechanism and can be of particular interest in patients with EGFR dependent RAS wild type or BRAF wild type left-sided tumor. Patient with right-sided tumor or primary resistant may not derive the optimal benefit from intermittent or chemotherapy-free strategies after an anti-EGFR based induction. So probably the patient who progress, there should be a chemotherapy-based regimen. Either the patient tumor has progressed or patient had a right-sided tumor. Next slide. So this is the data of ARMS study where untreated patient of RAS wild type, BRAF wild type metastatic colorectal cancer patient were given cetuximab plus FOLFIRI versus cetuximab induction with FOLFIRI and cetuximab maintenance. So here we can see that median PFS in cetuximab maintenance monotherapy was 10.62 months versus cetuximab plus chemotherapy was 11.9 months. And the estimated time to progression was almost similar, which was not statistically significant. Next slide. How we can do the second line anti-VEGF therapy post cetuximab, or we can give anti-VEGF followed by cetuximab. Next slide. So this shows us that if you give cetuximab plus chemotherapy versus bevacizumab plus chemotherapy, uh, the chances of getting a better, longer response in a left-sided KRAS wild-type tumor is when you give cetuximab plus chemotherapy versus followed by bevacizumab plus chemotherapy, and that will give you almost 1 to 2 months of PFS advantage. Next slide. So this is the arrow chart of how we can treat the patients better. So if you give cetuximab plus chemotherapy on first line, then you can give anti-VEGF plus chemotherapy. Some may argue that we should do the mutation test at each progression and do the NGS for the RAS wild type status and then take a call. But still, if you give cetuximab plus chemotherapy, probably after that anti-VEGF plus chemotherapy can give in, and that will give us some median overall survival of almost 40 months on the basis of Fire 3 CalGB and SOG study. On the other side, if you give BEV plus chemotherapy followed by cetuximab or anti-HF agent, the median survival is 28 to 32 months. And if you give anti-VEGF agent only, you are not able to give anti-EGFR therapy due to logistic lesions. The survival is mere 23.9 months. So bottom line is, if you have a rice valve type patient left side, probably anti-EGFR therapy has to be given early upfront. Next slide. So this is the metastatic colorectal guidelines, and usually we take splenic flexure as a cutoff site of left side versus right side. So in 2022, ISMO say that for cytoreduction or higher response rate for conversion therapy, as we have seen what Professor Sharma has shared to us, that in deeper study also the response rate was higher, but although it was not durable. So the data suggests us that even in the right-sided RAS wild-type tumor, if you want a reduction, a size reduction in the tumor, probably you can add a doublet chemotherapy along with an anti-EGFR agent, and there we can have a high response rate, and which will help us in conversion. Next slide. Next slide. So when cytoreduction is the goal, probably FOLFIRI or FOLFOX is an effective treatment for even right-sided RAS wild-type metastatic colorectal cancer. And this is on the basis of Crystal Taylor, was seen in Crystal and Taylor, and it does favor the use of rituximab. But if you see the CalGB SWOG and FIRE data, it was not favoring the bevacizumab. Next slide. So this is the pictographical review. If you give anti-HER2 therapy, anti-EGFR therapy along with FOLFIRI versus bevacizumab FOLFIRI, the reduction achieved is almost 57% versus 41%. And the median OS in patient who did achieve a response of more than 20%, that is 27.9% versus 23.2 months. So if you want a reduction anti-biological agent, probably EGFR inhibitors are better. Next slide. So this is again the same thing, that only cetuximab plus chemotherapy lead to numerically higher response rate versus this was not seen in the paradigm trial, where the response rate was almost equivalent to the bevacizumab arm when we use it panitumumab. Next slide. So this ISMO guideline also changes the shift in metastatic colorectal treatment landscape towards precision medicine, like you have to do liquid biopsy. Now CTC is also coming into picture. So this space is evolving rapidly, like you have to do CTC every 3 monthly, or you can do NGS on progression. So there's ongoing major research, and as we have seen that earlier, we are very newer molecule coming up with the data, which suggests us that there are very new treatment option will be available for various patient subset. Next slide. So to summarize, that updated guideline recommend tailoring first-line treatment approach according to tumor sidedness in RAS wild-type metastatic colorectal cancer. Anti-EGFR plus chemotherapy agents are now recommended as the only option in left-side RAS wild-type metastatic colorectal cancer, as per ISMO 2024 guideline. With cetuximab plus chemotherapy followed by anti-VEGF plus chemotherapy did give us 40 months in the left-sided RAS wild-type patient. We should continue anti-EGFR patient in maintenance setting to achieve optimum survival benefit without increase in toxicity, as recommended by guidelines and recent data from various studies. In right-sided RAS wild-type anti-EGFR plus chemotherapy can be offered when cytoreduction is the goal. Otherwise, it is still in an array, although the guidelines suggest that we can use it, but the data is still having a debate over it. Thank you for the patient listening. Over to the organizer.
Thank you, sir. Thank you so much for such a lucid talk. And I would request the chairperson to invite the next speaker.
So, for the next talk, I would like to invite Dr. Sunil Chopde. He's a senior consultant medical oncologist at Just Look Hospital and Research Center, Mumbai, and he's going to enlighten us on transforming patient outcomes with newer innovative therapies in first line advanced metastatic HCC. Over to you, Dr. Sunil.
Uh, Thank you for the invitation. Good evening to everyone. So I will be talking mainly on metastatic or unresectable SCC. Should I share the slides?
Yes, sir.
Yes, sir, go ahead if you can.
Is my slides visible?
Yes, sir, they are completely visible. Kindly make it full screen and then you can start.
So transforming patients' outcome with newer innovative therapies in first line advanced or unresectable SCC. We know liver cancer is the seventh most common cancer and fourth most frequent common cause of cancer-related deaths globally. Most of the patients are diagnosed in advanced stage with distant or locally advanced state, almost 45% of the patient. The 5-year relative survival rates are still low in SCC. For localized cancer, it is 31.3%, and with regional metastasis, it is 10.6%, and for distal metastases, it is 2.4%. According to Globocon data, liver cancer is the 11th most common type and eighth most common cancer for deaths, with SCC being the second most common cancer death in men. Uh, Number of cases 38,703 and deaths due to SCC were 36,953. It is more common in males than female. Median age is 40 to 70 years with risk increasing with the age, and incidence in Indian patients with cirrhosis it is 1.6%. So this is pathophysiology, inflammation, and immune dysregulation, which contributes to the SCC development, viral infection, NASH, or chronic alcohol abuse causing ASH, which causes the cellular state and cell death, and leading to dysregulated liver immune work, finally leading to fibrosis and cirrhosis. There are multiple immune escape or evasion mechanisms, including overexpression of CTLA4 and PDL1 and inhibition of antigen presentation. So these are the risk factors like viral infections, substance abuse, metabolic causes, and other leading to chronic inflammation and immune dysregulation, finally leading to SCC. So etiological fractions in patients with hepatocellular carcinoma in India with or without a background of cirrhosis. So NAFLD was the most common cause, followed by viral hepatitis in India. Moving ahead to management of advanced unresectable SCC. So this is updated BCLC staging. Advanced stage includes BCLC-C, patients with extrahepatic spread with liver function or PS1-2, where we use systemic treatment. This we are going to discuss detail further. Patients with early stages, they can be managed either with surgery or liver transplant or local therapies, including resection and TACE or TARE. Evolution of systemic treatment, the first drugs were sorafenib, then came regorafenib. Now newer TKIs like lenvatinib and cabozantinib has come up. Immunotherapy, including pembrolizumab, atezolizumab, bevacizumab, and nivolumab plus ipilimumab. And recently, in 2022, we have a tremelimumab and durvalumab. This is based on SHARP and REFLECT trial. Lenvatinib was approved in the first line treatment of SCC. Here in sharp trial, sorafenib showed median OS of 10.7 months compared to 7.9 months in placebo, with median PFS of 4.1. Lenvatinib, with lenvatinib, median OS was 13.6 compared to 12.3 with sorafenib, and median PFS of 7.4 months. Adverse event associated with sorafenib, as we all know, diarrhea, weight loss, hand-foot syndrome, and hypophosphatemia. And lenvatinib, most of the patients will have hypertension, diarrhea, decreased appetite, and decreased weight. There was a modest improvement in the overall survival and considerable side effects. So there was an unmet need for the better clinical outcomes in the management of SCC. Then came immune checkpoint inhibitors and anti-VEGF therapies. So this is the Embrace 150 trial where they evaluated atezolizumab and bevacizumab versus sorafenib in first-line advanced unresectable hepatocellular carcinoma. Included patients of locally advanced or metastatic or unresectable SCC who has not received any previous treatment. Stratification were region, performance status, macrovascular invasion, and extrahepatic spade, as well as baseline AFP less than 400 or more than 400. Patient received atezolizumab 1200 milligram Q3 weekly plus bevacizumab 15 milligram per kg, and in other arm, patient received sorafenib 400 milligram twice a day. The primary endpoint was OS and PFS. So this combination has shown improvement in median OS and median PFS in advanced hepatocellular carcinoma. 18 months OS was 52% compared to 40%, and median PFS at 18 months was 24% versus 12%. Median OS of 19.2 months versus 13.4, and median PFS of 6.9 versus 4.3 months. In subgroup analysis, the combination has not shown significant improvement in non-viral subgroup. It has benefited viral subgroup, but no, in non-viral subgroup, there was no benefit. Safety and toxicity wise, more than 10% of the patient have a affected frequency of adverse event in either arm, and more than 4% difference in between arm. Most common side effects were hypertension, proteinuria, loss of appetite, and diarrhea. Dual checkpoint inhibitors. So rationale for combining was combining anti-CTLA4, which acts lymphoid complement to increase the number of T-reactive cells. Anti-PD-L1 or PD-1 acts in the tumor microenvironment to prevent T-cell inhibition. This enhances the synergistic anti-tumor activity. So durvalumab and tremelimumab, this increases the anti-tumor activity by reversing T cell exhaustion and following T cell activation. This is the mechanism of action. CTLA4, it regulates the T cell activation in the lymph node. Tremelimumab blocks CTLA4, allowing the T cell activation. PDL1, it shows adaptive resistance. It induces T cell exhaustion in the tumor. Durvalumab is a PDL1 blocker which reverses the T cell exhaustion. So here both the tremelimumab, it blocks suppressive T cell signaling in the lymph node by inhibiting CTLA4, while durvalumab inhibits PDL1 PD1 axis. High dose T combined with this uh, durvalumab result in initial burst of T cells in patients with NSCLC. Similarly, in melanoma, as initial dose of ipilimumab and nivolumab, this causes proliferative burst in the T cell. Uh, these ICA regimens which incorporate high doses of CTLA4 combined with PDL1 are often associated with improved OS compared to those with lower doses of anti-CTLA4 but increased toxicity. So this was a phase 2 study, study 22, which evaluated tremelimumab plus durvalumab in unresectable hepatocellular carcinoma, including it has a stride regimen. Uh, the arms were patient received dosing as tremelimumab 75 milligram or uh, is part 1 initially 75 plus durvalumab with 40% patient, then Patient received these combinations T75 plus D, then durvalumab and uh, tremalumab 75 milligram, 4 weekly, 7 followed by 12 weekly. The part 3, it has 4 arms where patient received tremalumab 75 plus durvalumab 450. Sorry, and it has durvalumab. It has 64% stride regimen, which showed that tremalumab 300 milligram single dose and durvalumab 1500 milligram 4 weekly. So this stride regimen showed highest efficacy compared to the other combinations with median OS of 18.7 months. With durvalumab, it was 13.6 months. So longest median OS was with stride regimen. Median OS was 3.6 months longer than other arms. One event was observed at 27 months in the stride arm. So this demonstrated acceptable safety profile with no new safety signals. Based on this, Himalaya, this was a phase 3 trial, randomized open label multicenter study of tremalumab and durvalumab as the first line therapy in patients with unresectable hepatocellular carcinoma. This is a study design. Patient more than 18 years unresectable SCC, BCLC stage of B or C with no prior exposure to systemic therapy and good performance status PS01 and child plug class A were randomized in 4 arms. Arm A received stride regimen, durvalumab 1500 milligram monthly and tremalumab single dose of 300 milligram. Arm B received durvalumab 1500 milligram 4 weekly. Arm C received sorafenib and Arm D 75 milligram 4 doses. So this combination stride regimen, this was approved by FDA for first line treatment of SCC. This was previously known as T300 and was consistent with the dose priming with tremalumab plus 4 weekly durvalumab. So this is single tremalumab and regular interval durvalumab, that is stride regimen. This is the demography. The study had 83% of the male patient in all 3 arms. Median age was 65. 40% of the patient were Asian, including Japan. Viral etiology, almost in each arm there were 60% of the patient with VV and SCV infection. Performance status wise, 60% patient has ECOG 0. BCLC staging, 80% of the patient were BCLC C and 20% patient were BCLC B. Child plug classification, almost all patients had child plug A. PDL1 positivity, 40% of the patient had PDL1 positivity and AFP more than 400 in 36% patient in this tried arm. Subsequent second line treatment is patient received in the form of targeted therapy or anti-angiogenic therapy, immunotherapy, or some patients received cytotoxic chemotherapy. This stride regimen demonstrated a significant statistical improvement in median OS versus sorafenib. Patients who received stride has a 22% lesser risk of death compared to who has received sorafenib. Hazard ratio was 0.78. At median duration of follow-up of 33.1 month, median OS events were 66% compared to sorafenib. Median OS was 16.4 months and versus 13.8 months. At 36 months, 30.7 versus 20.2 months was the median OS. This is a subgroup analysis where it showed improved OS compared to sorafenib across all subgroups, including infective hepatitis. Tumor response or overall response rate and duration of response was higher for stride. Overall response rate was 17, was seen in 79 patients with 20%. Median duration of response was 22.3 months. Median time to response was 2.1 month compared to 3.7 months in sorafenib. This was well tolerated compared to sorafenib with lower rates of adverse effect and grade 3, grade 4 side effects. If we see grade 3, grade 4 side effects were uh, seen in 52% patients. Here it was seen in 50.5% patient. Any grade 3, 4 immune-related adverse effect occurred in 12.6% of the patient. So these are the side effects. So most common side effects were rash, pruritus, and diarrhea. Treatment-related hepatic or hemorrhagic events happen were only 0.5 versus 1.1% in other arms. Other side effects like LFT derangement as well as esophageal varicose hemorrhages were less with the stride regimen. This is a 5-year overall survival and OS by tumor response measure from phase 3 Himalaya study uh, of tremelimumab plus durvalumab in unresectable hepatocellular carcinoma. This updated slide demonstrated sustainable OS benefit versus sorafenib with OS rates of 19.6% at 60 months versus 9.4% in the sorafenib arm, with median OS of 16.4 months and hazard of 0.76. Also, the benefit was consistent across all subgroups irrespective of the PDL1 expression, viral etiology. Here also we can see the benefit was consistent in all participants, hepatitis and non-viral uh, cirrhosis
Sir,
patients
sorry
also.
to interrupt you. Kindly conclude your talk in next 2 minutes.
5-year overall survival by baseline liver function from phase 3. So these were the baseline characteristics we initially described. This was 5-year OS based on the ALBI grading. So patients with ALBI grade 1 had median OS of 23.4 months. Those with grade 2 or 3, the median OS was less. So this is the first category 1 regimen, tremelimumab plus durvalumab used in hepatocellular carcinoma. So to conclude, STRIDE regimen has showed OS benefit, tolerable safety profile, benefit across all subgroups, and with all etiologies of hepatocellular carcinoma. Thank you.
Thank you, sir. Thank you for the excellent talk. And thank you to the Lalit Sharma, sir, for chairing the GI session. And as we move forward, I would like to invite for the GU session, the chairpersons on board are Dr. Ajay Papna, sir, who is Director and Head of Medical Oncology at Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur. Over to you, sir, to invite the speakers.
Yeah, thank you to all the organization, Dr. Sandeep Jasuja. So now we are entering into the GU Cancer Session 2. And my co-chairpersons are Dr. Lalit Mohan Sharma, Dr. Pramod Kumar, and Dr. Mukesh Chaudhary. We have 2 speakers in this session, Dr. Bharat Vaswani, who is a senior consultant medical oncologist and hematologist at Yashoda Hospital, Sikandrabad. And second speaker will be Dr. Rohit Swami, consultant medical oncology, Narayan Multi-Speciality Hospital, Jaipur. Dr. Bharat Vaswani will be delivering ESCO GU update. Over to you, Dr. Bharat.
Sir, good evening. First,
Yeah.
let me, sir, most important, am I audible, sir?
Yes, audible,
I'll
visible.
just, I'll share my slides.
Yeah, sure.
And are my slides visible, sir?
Not yet. Yeah, now. You can continue.
Yeah. Sir, are they visible now?
Yeah, continue.
Yeah. So first, let me thank Sir Bapna sir for a kind invitation. Sir is always a teacher and I learn every day from what sir puts up in Impact Group. So my talk in the next 20 minutes, sir, I have prepared well. I am covering the 6-7 abstract, which if you can hear from me, I think these are the most important abstract that were presented in ESCO GU 2025, which was between February 13 to 15, 2025. Let me start with a renal cell cancer. All of us know the treatment of choice in a first line in RCC is either a combination of IO-TKI or a combination of IO-IO. We had 3 trials in IO-TKI, Keynote 426, clear and checkmate 9ER, and in IO checkmate 214. So here we had the final overall survival analysis of one of the most important study, checkmate 9ER. Now, final follow-up results of checkmate 9ER. Here we were looking at the final overall survival, which I feel is the most important point, which probably helps us in deciding which drug should be used. So previously untreated first-line patient, Nivo Cabo versus sunitinib, overall survival and PFS was the primary endpoint. This was something that we know. 42% reduction in the risk of progression, twice the progression-free survival, or you have a reduction in the risk in terms of 42%. But this was what we were not expecting. Now, this is the most important point that was presented. So, yes, there is a statistically significant improvement in the overall survival when you combine Nivo, Cabo versus sunitinib, although this quantum is less, but statistically significant, 21% reduction in the risk of progression because of crossovers. Now, when you look into responses, again important when you see a fastly growing or a visceral mets, 55% overall responsive, but when you look into the clinical benefit rate, it goes around 85 to 90%. So 6.5% were progressive disease. So one of the most potent combination that we have along with the other two. More importantly, what the patient took post progression on the first line. So what it is observed is more number of patient on sunitinib as expected took the second line. 43% of the patient or subsequently only took the second line in Nivo Cabo on. And again underlying the fact that you should use the best option upfront, because more than half of the attrition was there when they gone to the second line. Majority of the patient on sunitinib in the second line were able to take the IO drug. So probably yes, some sort of a quantum of benefit reduces, but again, it re-emphasizes the fact that IO should be there as a part of first line. So this trial suggested that long-term benefit was there and toxicities were manageable. Now, this was something that was presented in the what we say the expert section. This was in nutshell. You had IO 12.3 month was the PFS, and when you look into the combined, so first line IO probably IO TKIs has a better PFS. So earlier disease control with IO TKI because there is no crossing over of the curve, but you have more durable response when you say IO. And when you look into the overall survival, here probably what we tell our patient is 4 year is tentative overall survival when you give this combination. Now, when you look into the IO, probably it looks better, but again, this was different population. So how do you decide? This was something I liked and I thought I'll discuss. How do you decide IO versus IO TKI? Sarcomatoid, the better data is with IO. When you talk about visceral mets or bone mets, probably IO TKI because you need rapid responses. Where should I use Cabo Nivo? Probably in bone mets, because what has been seen in Cabosun study as well as this study, in bone mets, cabozantinib works the best. Should I do a PDL1 in RC? So the answer is no. But if you are doing it and if you see your PDL1 very high, then if you see the data, IO works very well when your PDL1 is positive. So although we don't do, but if you have to choose between the two, patient is eligible for both, fit, less tumor burden, I think PDL1 might help you in choosing whether you should use the IO. This was what was given in the comment section. The second study, again, we know doublet is better than single drug. This question was Cosmic 313, which asked that whether triplet, which is Ipi Nivo plus minus cabozantinib, is better than a doublet, which is Ipi Nivo. So probably again a pertinent question that they asked. So first line treatment, Cabo Nivo Ipi followed by Cabo Nivo. In the other arm, Nivo Ipi followed by Nivo maintenance. The primary endpoint was PFS OS. There was no crossover allowed. This was most important. There was improvement in progression-free survival. That was expected with an 18% reduction in the risk of progression. But the most important endpoint was there was absolute no improvement in OS. So what does this trial suggest is the no significant difference in OS. Triplet is not better than doublet. So the basic question, why triplet did not do better than triplet? So 4 reasons. Lesser. If you see the average dose when you give a triplet was only 22.4. Fewer patients were able to receive 4 cycles of ipilimumab, only 58 out of 100. And last but not the least, 92% of the patient there was dose reduction. So probably triplet is more toxic. Less people are able to take 4 doses, and the median dose of cabo that was given in triplet was lesser. So 2 studies. Then what are pivotal studies in urothelial cancer? So there were 2 pivotal studies. All of us know that the standard of care in those patients where we have not given, not like a Niagara, but we have followed a chemo 4 cycles. If there is a residual disease, we give adjuvant nivolumab for 1 year. So what this trial, this was again the final overall survival. This is what also is expected when you say the DFS is more, what about the OS? So this was the final OS analysis in the adjuvant Nivo study in muscle invasive bladder cancer, checkmate 274. What did this study say? So any residual disease post neoadjuvant or a patient who might have not taken a neoadjuvant, maybe due to platinum ineligibility, T3, T4 or node positive, Nivo for 1 year versus placebo. This is something that we knew, 37% reduction in the risk of progression. It was nearly thrice if you see placebo 8 versus 25 months. But what is more important is, yes, there is an improvement in OS, and actually this was the most important thing. And when you take the hazard ratio, 30% reduction in the risk of progression. So again, a good study, a robust data. And when you see, should I do a PDL1 here? So probably when you are short of money, or because if you see the FDA, it can be given in all comers. But if you see the EMA guideline, European, they approve only in those with PDL1 of more than 1%. And when you look into the analysis, the hazard ratio is 0.48 in OS. So nearly twice. So 48%, 52% reduction in the risk of death. If you see the absolute benefit, nearly 20% patients are still surviving more at the end of 3 years. So no two thoughts all over. I think I'm okay with it, but more than one, definitely a must go. So OS data from interim analysis favors this adjuvant, and this quantum of benefit is more when your PDL1 is more than 1%. No new safety signal. So 3 trials till now. Atizo failed, checkmate, and Ambisetter, which is a Pembro, succeeded. But FDA approval has come only for Nivo. In adjuvant Ambisetter, probably you still have to wait till you get a FDA approval. So at present, one drug with a DFS as well as OS advantage. Without about metastatic urothelial cancer. The entire world of metastatic urothelial cancer has changed with the final analysis of EV302 study. Absolute no did it if you have affordability, because now Infotumab has come to India in the month of March. So we know platinum eligible, ineligible, Pembro, Infotumab vedotin, which is a drug antibody again, Nectin-4 is the drug of choice. So this was the updated analysis at 24 months. We had already analysis, but it is 1 year further follow-up, which was presented in ESCO-GU. So untreated metastatic urothelial cancer, EV Pembro versus the standard of care, PFS-OS. So unlike all studies, this is the same. The best part of it, at 3 years, 37% of the patients are still progression free. Look into the PFS. 1 year, no drug beyond 7 or 8 months has achieved. So this is nearly twice any standard of care. 52% reduction in the risk of progression against the standard of care. I can only remember the Durexican study where these ratios were very good. Now this is the most important. At the further follow-up of 1 year, this overall survival continues to improve, 33.8 months. So you are looking into stage 4 metastatic urothelial cancer with a survival more than 2.5 years, a 49% reduction in the risk of death. Amazing data. About duration of response. So if you respond, your duration of response is average 2 years. Again, a very exciting data. So no two thought, this is a treatment of choice, better PFS, better OS response. And this is a durable response with nearly 2 years once you respond. How does this data means to clinical practice? So I think it is now clear. You have seen the guidelines also. In a treatment name advance on metastatic urothelial cancer, EV Pembro is the drug treatment of choice. Suppose if I cannot give this drug due to maybe cost constraint or unchecked peripheral neuropathy, then you think of doing the other drugs. The third part of it, prostate cancer. So 2 pivotal studies here. What we all know is, in a normal de novo hormone sensitive prostate cancer, this was not the standard of care. The standard of care is either a doublet ADT with either a abiraterone or amides Inza-Epi or darolutamide, or nowadays with Aracin and Peace-1 study, a triplet in all fit synchronous or metaclonus high burden disease, and in some metachronous high burden disease also. But the $1 million question is, if I have to use a doublet, should I use a abiraterone or a amides? Probably this is one of the most practical thing that I found in this ESCO-GU. I have both the option available in a doublet, abiraterone or amides, Inza, Epilu, what should I use in the first line? So that has been answered in this top cap meta-analysis of individual participant data, which should be used among the two. Now, this was the studies that looked into it. You can see a lot of things. This slide covers everything. How many are high burden, but I don't think that should be discussed now. What is important is how much you gain. 21% absolute improvement at
Sir,
5 years.
sorry to interrupt you. Kindly conclude your talk in next
Can't be
2 minutes.
concluded. Give me 20 minutes, ma. I have to tell these things. If there is and in terms of overall survival, there was a 13% improvement at overall survival at 5 years. But the most important thing, should I use amides or abiraterone? So what you see is the quantum of benefit in both is lesser as the age improves. But above 75 years, when you look into the abiraterone data, that is not so impressive. Now, this is the most important slide. Younger age, the PFS and OS benefit in abiraterone is very good, 25 and 16%. Now, when you look above 75, there is no benefit of giving abiraterone, maybe due to comorbidity and the higher death. So what did they say is no OS benefit for abiraterone in age more than 75 years. So what this trial concluded is there is a clinical benefit is clear for all the tablet. But when you talk about younger patient, you can use any of the two. For older patient, probably abiraterone may not be the right drug to use. This was the best slide that I got in the comment section. More than 75 use ADT or either any amides, not abiraterone. In a low volume or unfit for chemo, use doublet. High volume fit for chemo, use triplet. One of the best data to say what you have to use. The next data. What about combining your PARP inhibitors with either of these new tablets? So you had 3 studies. Olaparib abiraterone, niraparib abiraterone, so magnitude, propel, and telapro. So there was a final OS analysis of this telapro. More important is everyone knows that if you have a BRCA mutant or even a HRR, you can use the combination. Important is in unselected, should I use the combination? That we don't know. So when you see this data, Talapro versus Inza versus placebo versus Inza, in those patients who have not received these drugs, either enzalutamide in the hormone sensitive, that is the most weak point. Most of us use this drug or abiraterone in the sensitive setting. Somehow when you have not used, can you use it later? So 21% were HRR deficient, 78% was non-deficient. Overall, there was a statistically significant improvement in hazard ratio. 13% is a good benefit. And when you look into the final analysis, again, this was statistically significant. Everyone knows this will be positive. For me, the most important thing was if there was no hormone alteration, so non-HRR or non-BRCA. Unfortunately, when you see it crosses 1, so probably there is still no benefit or you should not use this combination in non-HRR subset. So no statistical significant improvement in OS in non-HR subset. This is what we know, and I think again it reiterates the point that combination can still be used only in BRCA or in a HRR. Direct improvement, 8.8 improvement, but unfortunately, you still can't use this combination in non-HRR subset. Whenever you think of it, you use it in BRCA or a HRR subset. The last part. You give 5FU, you give taxanes, you give cisplatin. This was the first bigger study to say that you can now start using immunotherapy in the penis cancer. So a new treatment option for carcinoma penis. This was what we saw. So upfront T3N1 or metastatic disease, no previous chemo or immuno, 4 cycles of cis and semiplimab. This is followed by a maintenance semiplimab, and you need to see a clinical response rate. Locally advanced 24, metastatic 76. The most important, think of your response rate when you don't use the immuno. It is 40 to 45. So by adding a immuno combination, you are increasing this benefit rate to 62, which is the best among any data presented. Now, when you look into clinical benefit rate at the end of 6 months, it is still 50%. So probably, yes, it is synergistic to the chemotherapy. Importantly, at the median overall survival is 15.5 months. Think of your historic control. In a metastatic CA penis, it is around 12 months. So yes, now this combination, or we have started using Nivo that is available, but yes, now we have first proof of concept that immunotherapy definitely can be added on with a clinical benefit rate of 62%, PFS of 6.2%, OS of 15%, and probably a new treatment option. Now we have a data to support it. So if I have to summarize, two important abstracts in renal cell, long-term follow-up data confirms survival advantage of IOTK as a first line, 4 year approximately, any of the three. Triplet not better than doublet as seen in the COSMIC study. In urothelial, now we have a final updated analysis of adjuvant nivolumab 274, and it shows that it has a survival advantage. Pembro info, we have with a long-term data, again, also consolidates this view that this combination is the best drug in first line in cisplatin eligible as well as ineligible. Prostate, prefer amides in the Epiduro over abiraterone in patient with a hormone sensitive de novo in above 75 years of age. Combination of talazoparaben and inosine has minimal improvement in OS, but it is not statistically significant in non-HRR subset. And last but not the least, yes. Now we have a emerging data now, proper data to say that immunotherapy is one of the options that we can use in metastatic CA penis. I end my talk with the famous quote of Socrates: "The secret of change is to focus all your energy, not on fighting the old, but on building the new." I thank you all for a patient hearing.
Wonderful, Dr. Bharat, as usual. It was really a very enlightening to listen to you and all the
Sorry,
newer.
sir, I prepared it, so it was always
No,
very.
it was really very enlightening. We can really benefit from this data. Thank you very much again.
Thank you, sir. Thank you.
Can I invite now Dr. Rohit Swami to speak on maintain to extend the right approach for maximizing overall survival in metastatic urothelial carcinoma?
So good evening,
Bharat,
sir.
you
How
can
are you?
share your slides. Hi, Bharat. Hi, Rohit.
Uh,
Yeah, please continue.
Yasika, please share my slides.
Yes, sir. Just a second.
Yeah, so good evening, everyone. I'll be discussing how to extend the survival in metastatic urothelial carcinoma by sequencing the variable options of treatment available to us at present. Next slide, please. So a few years back, we had only option of giving first-line chemotherapy, followed by observation and on disease progression. Next slide, please, Yashika. And on disease progression to initiate second-line therapy. So first line chemotherapy, platinum-based chemotherapy definitely have good response rate of around 75 to 80%, but median PFS remained only 6 to 8 months. Median overall survival remained only 13 to 15 months. By this approach, giving first line chemotherapy, waiting for progression, and giving second line chemotherapy. Next slide, please. So there was always a unmet need in the first line setting unmet need to give chemotherapy or other options available to get maximum PFS and maximum survival benefit in the first line setting. Next slide, please. So there were 3 studies conducted which compared immunotherapy alone with the chemotherapy, platinum-based chemotherapy in metastatic urothelial carcinomas in the first-line setting. Danube compared durvalumab, tremelimumab combination along with chemotherapy. There was no survival benefit in durva arm versus chemotherapy arm. Keynote 361 compared pembro and chemotherapy. There was no survival benefit in pembro arm. And similarly, IM Vigor 130 compared atezolizumab with chemotherapy, and there was no survival benefit. Next slide, please. So is there any role of chemotherapy plus immunotherapy in the first line setting? Next slide, please. Yashika. So coming to the
Sir, are you able to see the next slide?
I am not able to see the next slide.
Hello?
I am not able to see next slide.
Sir, I have switched the slide. Next slide.
Yeah. So, is there any option of giving immunotherapy plus chemotherapy in the first line? So, I am Immucure 130. There was no survival benefit of atezolizumab combination with chemotherapy and platinum as compared to chemotherapy. And similarly, in Keynote 361, there was no survival benefit. Though interim analysis in both of these studies showed that there is survival benefit, but final analysis, there was no significant overall survival with the addition of immunotherapy with the chemotherapy, either atezolizumab or pembrolizumab. Next slide, please. So what we are discussing is what approach we have to go. Either we should go with chemotherapy followed by immunotherapy maintenance, or we should go for upfront chemotherapy plus immunotherapy, or we should go with EB plus pembrolizumab in the first line, followed by chemotherapy in the second line. And next slide, please. Platinum eligibility criteria definitely remain an important point to decide which option has to be used. Next slide, please. So coming to Javelin Bladder 100 study, where first line chemotherapy, platinum-based chemotherapy, either cisplatin-based chemotherapy or carboplatin-based chemotherapy, 4 to 6 cycles were given. And after response assessment for the patient who received CR, PR, or stable disease, were randomized in 1:1 fashion to avelumab maintenance as compared to best supportive care only. These patients were further stratified according to the response they got from the induction chemotherapy, whether CR, PR, or stable disease, and sites of metastasis, whether visceral or non-visceral. Primary endpoint was overall survival. Primary analysis population was all randomized patient PDL1 positive population. Secondary endpoints were PFS, overall response, time to response, response duration, disease control, and safety and quality of life measures. Next slide, please. So, coming to the final outcomes of this study, coming to the primary endpoint of this study, there was significant median survival benefit with the avelumab maintenance as compared to best supportive care only following the induction chemotherapy. So median overall survival was 23.8 months in avelumab arm as compared to 15 months alone with the chemotherapy arm followed by observation. And at 2 year, overall survival probability was around 50% as compared to 38% with the chemotherapy alone arm. Best supportive care alone arm as compared to avelumab maintenance. Next slide, please. So if we go for the median overall survival, since from the very beginning, from the starting of the chemotherapy, this median overall survival comes around 30 months in avelumab arm as compared to only 20.5 months in chemotherapy followed by best supportive care arm. So there is 9.2-month improvement in median overall survival as well as 23% reduction in risk of death with the addition of avelumab and as maintenance after induction platinum-based chemotherapy. Next slide, please. And there was significant PFS benefit also with the addition of avelumab as maintenance, 5.5-month median PFS as compared to 2.1 month with the best supportive care alone. Next slide, please. Coming to the adverse events related to this treatment, so any grade of adverse event were around 77% in avelumab maintenance as compared to 1.2% in best supportive care alone. And most of these events were immune related. Most common was pruritus, followed by hypothyroidism, diarrhea, infusion related reactions, asthenia, fatigue, rash, chills. Next slide, please. And this overall survival was maintained regardless whether cisplatin was used or carboplatin was used. So you can give gemcitabine plus carboplatin or gemcitabine plus cisplatin followed by avelumab maintenance. So even cisplatin ineligible patient can also go with this approach, giving induction chemotherapy followed by avelumab maintenance, and median overall survival benefit was there with the addition of avelumab maintenance. Next slide, please. And the survival benefit as well as PFS benefit was well maintained. Whatever response you get with the induction chemotherapy, whether you get CR, whether you get PR, whether you get stable disease. Next slide, please. And the treatment population, around 61% of the population was Asian population, and these patients derived more than 10 months of median overall survival benefit with the avelumab maintenance and 3 times higher PFS with avelumab maintenance as compared to best supportive care only. Next slide, please. So how long would you like to continue avelumab maintenance? So we all know we have to give maintenance till the disease progression. And this Javelin study also showed that more than 20% of patients received avelumab beyond 2 years, and around 28% patients received avelumab more than 12 months, and around 50% of patients received more than 6 months. So once you receive stable disease or good response with the avelumab, around 20% of patient goes beyond 2 years of avelumab maintenance. Next slide, please. So coming to real world studies of this approach, chemotherapy followed by avelumab. Next slide, Yashika, please. So there were three real world studies conducted, one in US, Patriot 2, one in France, which was the largest real world study, evidence, and one was in Italy, READY study. So these are real world evidence which shows that the avelumab maintenance can give us better median overall survival, can give us better overall survival benefit as compared to chemotherapy alone. Next slide, please. So all of these studies showed us that the 12-month overall survival rates were similar to Javelin study. In Javelin study, it was 71.3% 12-month overall survival rate, whereas in Evidence it was 65.4%, and in Ready it was around 70%. And median overall survival was also similar in all these studies and were by far matched with Javelin 100 study. Next slide, please. So Evidence was the largest study, including around 600 patients going with chemotherapy followed by avelumab maintenance. Next slide, please. So if we see this Evidence study, so the patient who received first-line induction chemotherapy followed by avelumab maintenance followed by second-line EV. Next slide, please, Yashika. So median overall survival of around 40.8 months was reached. So that is the largest median overall survival ever reached in the metastatic urothelial carcinoma. Even if we can see in the first line setting of EV and pembrolizumab, we get on the 3-year follow-up, we get the median overall survival of around 33.8 months. And then for the second line option with the EV and pembro, we don't have left much second line options. There is no data which suggests that the cisplatin will work after EV and pembrolizumab and whether it is safe or not. Next slide, please. Coming to the approach involving immunotherapy plus chemotherapy in the first line setting, followed by immunotherapy maintenance, followed by second line therapy. So as we discussed earlier, IM Vigor 130, there was no survival benefit of addition of atezolizumab with Gemcis as compared to Gemcis alone. Keynote 361, there was no survival benefit of pembro with Gemcis as compared to Gemcis alone. Checkmate 901 was the positive study which showed that there is significant survival benefit of addition of nivolumab with Gemcis as compared to Gemcis alone, though the survival gain was around 2.8 months only. Next slide, please. So Checkmate 901, only cisplatin eligible patients were selected, and these patients were randomized in 1:1 fashion to the nivolumab and Gemcis combination as compared to Gemcis combination, and patient were further stratified according to next slide, please. According to tumor PD-L1 expression, presence or absence of liver mets. And then post 6 cycles, these patients are kept on the nivolumab maintenance. Next slide, please. Coming to the result of Checkmate 901, so median PFS in Gemcis arm was only 7.6 months as compared to 7.9 months in nivolumab plus Gemcis arm. So only 0.3 month, 9 days of PFS benefit was there. And if it comes to survival analysis, 18.9 month median survival with the chemo alone as compared to 21.7 months with addition of nivolumab. So we get the gain of around 2.8 months of median overall survival. Next slide, please. So if we compare, though the cross-trial comparison is not a good thing and not a eligible thing, but if we compare Javelin 100 with the 901 data, so next slide, please, Yashika. So median overall survival was around 30 months with the chemotherapy followed by avelumab maintenance as compared to only 22 months with chemotherapy followed by nivolumab maintenance. And if we do the sequencing of EV after immunotherapy, that is EV after avelumab maintenance, we can get the higher odds as shown by the real world study of around 40.8 months as compared to no further more options are available with us. If we give chemotherapy and immunotherapy in first line setting, we are left with EV alone. And post Nivo and Gemcis second line EV, we don't have data at present. Grade 3 adverse events were only 20% with avelumab maintenance as compared to around 61% with chemotherapy plus nivolumab. Next slide, please. So these are the options available with us. According to Javelin Bladder, if we give first line chemotherapy followed by Bavencio maintenance, followed by subsequent line of therapy, we get median overall survival of around 31 months. If we give EV in the second line post progression of avelumab, we can get median overall survival of around 40.8 months. If we give first line chemotherapy followed by observation, followed by second line chemotherapy on progression, median overall survival around 23 months. And if we give Nivo plus chemotherapy followed by nivolumab maintenance, followed by subsequent line of we get median overall survival of around 21.7 months. Next slide, please. So, what if we give first line immunotherapy with TKI or immunotherapy with EV, that is drug antibody conjugate? So, Danube study where durvalumab and tremelimumab arm was compared with the chemotherapy alone arm, there was no significant survival benefit. LEAP 011 study where pembrolizumab and lenvatinib was compared with chemotherapy alone, there was no significant survival benefit or PFS benefit. But EV302 study showed that there is significant survival benefit as well as median PFS benefit, with the median overall survival reaching up to 33.8 months. Next study, next slide, please. So coming to EV302, all the first-line patients, metastatic urothelial carcinoma, PDL1 inhibitor naive were randomized in 1:1 patient to either pembrolizumab plus EV or chemotherapy alone. Next slide, please. And this study has dual primary endpoint, PFS by BICR or overall survival, and secondary endpoints were overall response rate as per RECIST and safety indications. These patients are further stratified according to cisplatin eligibility, PDL1 expression, presence or absence of liver mets. Next slide, please. So coming to survival data of this study, there was risk reduction of around 53% patients and median overall survival was around 31.5 months and as compared to only 16.1 months with the chemotherapy arm. And this was the follow-up of 17.2 months. Now we have the more mature data at the follow-up 3 years. Now we have median overall survival of around 33.8 months. Next slide, please. But what are the second line used after the EV plus pembrolizumab combination? So only 30% of the patient received platinum-based therapy, and the patient who received platinum-based therapy, as we discussed earlier, there is no data which shows that platinum works after EV and pembro combination. There is no data that whether the platinum is safe after the EV and pembrolizumab combination. Next slide, please. Coming to adverse events, so EV definitely have very high adverse event as compared to chemotherapy alone. Grade 3 adverse events are 15.5% as compared to 0.2% with chemotherapy alone. And some of the adverse reactions are very much alarming, like the skin reaction, which can escalate up to the Steven-Johnson syndrome, peripheral neuropathy, which are permanent peripheral neuropathy, both sensory, motor, then ocular disorder, dry eye, and hyperglycemia. These are the few worrisome side effects of EV as compared to the chemotherapy. Next slide, please. So a serious skin reaction, as discussed, Steven-Johnson syndrome can be there, even toxic epidermal necrolysis can be there. Patient has to be monitored very, very carefully for any kind of rash appearance after use of EV. Next slide, please. And coming to the other adverse events which are manageable but still permanent peripheral neuropathy, Steven-Johnson syndrome, ocular disorders, dry eyes, and hyperglycemia, where DM2 diabetes 2 is already a very big health problem for the India. Using EV giving peripheral neuropathy or diabetes appears to be quite toxic approach. Next slide, please. So comparing Javelin 100 with EV302 data, so if we go for median overall survival for cis-eligible patients, cisplatin eligible patient, it was 31 months with Javelin as compared to 31.5 months with EV302. Now it is 33.8 in 3-year analysis. Only 73, around 73.8% of patients in the Javelin 100 study received cisplatin-based chemotherapy as compared to only 30% of patients who received carboplatin-based therapy in this study. So comparator arm was also weak as compared to EV plus pembrolizumab arm. If we go for PFS, if we include real-world evidence, so real-world evidence gives us PFS of around 13.6 months with avelumab maintenance followed by EV, as compared to 12.5 months with EV and Pembro in the first line setting. And then grade 3 adverse events around 20% with avelumab approach as compared to around 56% with first line EV and Pembro. And then again in the second line, we don't have any much more options available with us if we give EV plus pembrolizumab in the first line. Next slide, please. Coming to quality of life data, so definitely avelumab has lesser side effect, well-maintained quality of life as compared to EV plus pembrolizumab in first line up. Next slide, please. So NCCN guideline endorses all of these three options as a category 1 options. Most preferred option is pembrolizumab and enfortumab vedotin in the first line setting because of the robust median overall survival of around 33.8 months. Other options are GEM-CIS with nivolumab in cisplatin eligible patient only, and GEM-CIS or GEM-carbo followed by avelumab. So these are three options available with us in the first line setting in the patients having metastatic urothelial carcinoma. Next slide, please. So if we go with the first line GEM cisplatin with nivolumab, only in the cisplatin eligible patients, we get median overall survival around 21.7 months. If we go with first line platinum followed by avelumab maintenance, we get around 30 months of median overall survival. If we go with EV plus Pembro, first PFS is good and median overall survival is around 33.8 months. And if we go with first line platinum followed by avelumab maintenance and second line EV on progression on avelumab, we can get median overall survival of around 40.8 months as shown with in real world studies also. Evidence showed 40.8 months and Japanese real world study showed around 40.3 months of median overall survival. Next slide, please. So summarizing my presentation, platinum-based combination of chemotherapy followed by avelumab maintenance is a good option available with us. Median overall survival of around 40.8 months can be reached if EV is used in the second line and first line chemotherapy and avelumab maintenance is used as shown by the real world data. And sequencing with available agent is very much important to increase overall survival in these patients. Avelumab maintenance as well as first line EV and Pembro as well as first line GEM-CIS and nivolumab. All the three are category 1 option available with us. More safety and second line EV after avelumab maintenance can give us better median overall survival. Thank you. Thank you everyone for patiently listening.
Thank you, sir. Thank you for the excellent presentation. And I would also like to thank Dr. Ajay Bapna, sir, and Dr. Lalit Mohan Sharma, sir, for chairing this session. As we move forward for the session 3 on hematology, I would like to invite the chairpersons, Dr. Hemant Malhotra, sir, who is Director Oncology at Sri Ram Cancer and Super Specialty Center and Professor and Head Department of Medical Oncology at Mahatma Gandhi Medical College Hospital, Jaipur, and Dr. Upendra Sharma, who is Senior Consultant Hematologist and Hemato-Oncologist at Bhagwan Mahavir Cancer Hospital, Jaipur, to chair the next sessions and to invite the speaker. Over to you, sir.
So thank you very much. Am I visible and audible? Can I go ahead?
Yes, sir.
Okay, thank you very much. So many thanks on behalf of my personal behalf and on behalf of my co-chair, my very good friend, Dr. Upendra Sharma, for this opportunity. Thanks to the organizers, especially Dr. Jasuja, for giving us this opportunity. So this session is the session on hematology. We start with the panel discussion, primarily focusing on the new agent in chronic myeloid leukemia, the STAMP inhibitor, asciminib. Then we have two talks by leading experts of the country, one on DLBCL by Dr. Prakash Shekhawat, and then one on relapse refractory multiple myeloma by Dr. Dinesh Burani. So I'd like to hand over proceedings to my co-chair, Dr. Upendra Sharma, to take the program forward. And thank you very much. And I hope you enjoy this hematology session. Thank you. Over to you, Dr. Upendra.
Thank you, Dr. Hemdota, sir, for those kind words, introduction. Is always happy to see you, sir, in these meetings. Your blessings are always there. You always guide us in all hematology meetings. So I'm thankful to Dr. Sandeep Jasuja for giving us opportunity for this hematology session. So for this first session on hematology, I invite Dr. Dinesh Bhurani. He will be moderating a panel discussion. The topic is asciminib, on asciminib, ask the stamp inhibitors on second line, plus line treatment in CML patients. Dr. Dinesh Bhurani will introduce his panel discussion members. Over to Dr. Dinesh Bhurani, sir.
Am I audible?
Yes, sir.
Yes, sir, you are audible. All the panelists are requested to kindly switch on their video. Sorry to interrupt, sir.
Chief Sharma, Dr. Nivedita. These are the slides provided by Novartis. We are going to talk about we are the stump experts. So bridging gaps in the CML care in second plus line treatment. So we're not going to talk about the front and the second line plus. Is Vishnu there?
Yes, sir.
You're not visible.
Yes, sir.
So this is a disclaimer. My slides are visible?
Yes, sir.
Okay. So this is a case. 1 second. Let's put this in. 6 months history of fatigue, general malaise, and 12 kg weight loss. Mild tachycardia, palpation of enlarged spleen. Is an adult, extending 10 centimeter below the costochronic. White cell count of 3000, hemoglobin of 10.1, MCV 86, neutrophils 41 with the left shift, blast are 5%, basophils are 5%, and the platelet count is 4,900. We can see the massive spleen. You can see the bone marrow and both the aspirate and biopsy. Why was the flow cytometry done? I don't know. It's not required. Cytogenetic shows the XY 922, and the fish also confirmed the presence of 922 with the BCR-ABL. As a fish is showing 84% of BCR-ABL. Initiated on imatinib, 400 milligram daily. Complete hematological response at 2 months. At 9 months, lack of complete cytogenetic response and the major molecular response. So the BCR will less than 0.1. So this was not there. So because of the lack of complete response, imatinib was changed to dasatinib. Should this be changed at 9 months, Vishnu?
No, sir. I will change by 12 months.
I think that's an important point for everyone.
Sir, one question from my side. So, sir, for calculation of ELTS score or SOCAL score, would you consider flow cytometry blast or morphology blast on peripheral smear?
Morphology blast.
Because the blasts are 2.3% in flow cytometry, and on morphology it was 5%.
Take 5%.
Okay, sir.
Okay. And then he had because of this dasatinib, he had a multiple side effects. And at the same time, the goal was, the CCR and MMR was not achieved. So we will go to the questions. What could be the reasons for treatment failure? Can it classify to the treatment failure? Is it now 1 year and on dasatinib and CCR and MMR are not achieved? Nivedita. Nivedita? Is Nivedita there?
Yes, sir. Yes, sir. Sorry, my audio was not on.
Okay.
So, whenever we assess reasons for treatment failure, first and foremost, we have to be very sure that the patient has taken the drug properly in the proper dosage. So, assessing and emphasizing on compliance at every visit is very important. But if that has been maintained, the patient has taken the drug in the proper dosing as prescribed, then, sir, one of the reasons could be bad biology or any mutations that the patient might have acquired, which is making him not respond to dasatinib. So I think at 1 year, if the response is not being achieved, I think a mutation testing is warranted at this time point.
You don't achieve a 1% or you don't achieve a CCR.
Yes, yes. 1% is the goal at 1 year at least.
Yes, sir. Actually,
what I would like to say is that we usually do Sokal score, and if this is 45-year-old young male with 5% blasts, I think he would be in some intermediate or high Sokal, and my
Yes.
preference would have been Desativ initially.
He has a big spleen and other things.
Yeah, so and but though he was started on imatinib, and after 1 year, if he's not achieving the desired response, then obviously again we have the option of switching. And ideally, I would also prefer to switch to dasatinib if he's not achieving the response.
So, basically, so we need to do the scoring at the front. We need to be on the second generation if it is a high ELTS. Am I right?
Yeah,
Yes.
I prefer to do
Young
Sokal
age.
scoring and
Because
start on
elderly,
dasatinib.
we still opt for imatinib considering the side effect profile.
No, I would prefer to start with dasatinib. That is my choice nowadays. I start with second generation and not with imatinib, particularly.
65 years old, gentleman.
65, then obviously then I have to see other parameters also. Then imatinib may be preferred for elderly, but for young 45-year-old as his age is, dasatinib might be a better option.
Dr. Malhotra also can join. I suppose, I hope he's there. Dr. Pendra and Dr. Malhotra is there. So they can also be part of the discussion. What should we do? That's a day-to-day practice which we are doing it. So I think the most of the people are now going on dasatinib. What dose you start, Vishnu?
100 milligram, sir. 100 milligram dasatinib.
And you continue on 100 milligram.
Yes, sir.
Okay.
The patient who are intolerant to 100 milligram, we can like de-escalate to 70 milligram or 50 milligram. But starting dose is 100 milligram, sir.
You do not believe in low dose dasatinib?
No, sir. No, sir.
Nivedita?
Sir, my practice is that usually for older patients and for low Sokal score, I go for imatinib because I feel it's the best tolerated drug. With dasatinib, I do see a lot of side effects, but for like Dr. Sanjeev said, for younger fit patients with a high or intermediate Sokal second generation TKI most of the times. So the starting dose is 100 milligram, but I do see a lot of side effects, cytopenias, effusions. So with dasatinib, in fact, the few patients that are on nilotinib, I feel they do better than dasatinib. Dasatinib, I see a lot of side effects.
So you
Dinesh, can I make a comment?
Yes, sir. So that's what we want. You need to guide us, not to comment, guide us.
No, just like my suggestion. I'm surprised that most of the learned panelists and like the very bright young oncologists and hematologists are still sticking to Sokal score. I think it's time that we at least, in addition to Sokal, do the ELTS also.
I think
And I agree with
rather than
Sanjay.
talking about the so-called. So I agree with you.
Yeah.
Sir,
Yeah.
I am using ELTS. I am using ELTS, not so.
That's right. I think it's good that you document both in your page sheet. And, later on when you analyze, it will always be nice to have both the scores there available. And I agree with Nivedita, for a low-risk patient, either by Sokal or by ELTS, I would be happy to start imatinib. But I would very, religiously do the BCR-ABL at 3 months and 6 months because these are two really important time points.
So even a young patient, you will lose ELTS, you will go for imatinib.
If TFR is my, upfront objective, then maybe a second generation TKI and dasatinib and 100 milligrams, not 50 milligrams. Over.
So you opt for 50 milligrams, am I right?
No, I don't use 50
100.
milligrams.
Yeah, you're going for 100, I'm sorry.
Yeah, I only reduce if there is toxicity.
So I suppose for the younger age, majority the
Dinesh
TFR will be option. And then
Dr. Dinesh Burani, sir, I think for all our patients, we should start with, as Malhotra sir told, 100 milligram of dasatinib for either low risk or high risk ELT score, because that trial has it was limited to only low risk Sokal score. For dasatinib, we should go with 100 milligram, and if patient not tolerating, then we should decrease to 50 milligram. So what is the practice? You start with 50 milligram or 100 milligram with dasatinib?
That's what I want to know. I'm the moderator. So, The reason is as Nivedita says, the very few people, and there is a lot of side effect profile with the 100 milligrams. So if you see the pancytopenia, the early phase, you will see a pancytopenias. Then there are immunological reactions. So the pulmonary hypertension and the pleural effusions are significant comorbidities. So in fact, she is opting for nilotinib instead of dasatinib. So if you're going for 100, probably the nilotinib may be safer than 100 dasatinib. I mean, 100 also is tolerated, but the risk of the safety profile is lesser than the 50 milligram.
Sir, I don't know the experience of other panelists, but for me, I've had patient who's gone on the ventilator because of significant pleural effusion. There was a patient who had very, very bad diarrhea with dasatinib. Another old patient who had suboptimal response to imatinib switched to dasatinib. Unfortunately, we lost him. He had some cardiac comorbidities also. So with dasatinib and cytopenias leading to a lot of therapy interruption is also something that I do encounter a lot in clinical practice. And when I switch these patients to nilotinib, I see that I don't know, with the generic preparations, at least nilotinib is, I think, better tolerated.
Nilotinib will not give you the immediate side effects, but
Yes.
one is it has to be empty stomach twice a day. It's not a favorite drug for the young age groups when they are working.
Yes.
The second thing is you can have arterial diseases down the line.
Down the line. Very true.
You may not be able to continue beyond 4 to 5 years. I mean, if you're not stopping, then you have a long-term. If you see a data on the 10 years, the increased risk of arterial diseases are there. So that we should be aware of. Everything has its own pros and cons. I think everyone has differed now. Previously, everyone was imatinib. Now everyone has a different pathway to reach the goal. Anyway, that's a part. We will go to our topic. The rate of treatment failure increases. Why do people are not compliant with imatinib? What do you think? Even with the dasatinib and nilotinib, what's the reason? Is it a toxicity profile, or what makes them not being compliant?
So one is these vague, non-specific fatigue, muscle pains, these kind of vague symptoms which are very common with imatinib. So I think a lot of it is to do with the side effect profile. But more and more, I think if you keep counseling them at every OPD visit, compliance now it's not such an issue.
I mean, you have to be very vigilant and very on them. Otherwise, I think the long-term low-grade side effects of all these three drugs, imatinib, nilotinib, and dasatinib, sometimes leads to the compliance issue. Maybe lesser, but more or less we see it. So this shows you that despite the treatment progresses, resistance can prevent the patient from meeting their goals. So many people, either because of the intolerance or because of the side effect profile, may not be responding. So what percentage of our patients do not respond to first line? Do not meet the criteria to do we have this kind of some figures? Sanjeev, what's your experience? You have 10 patients, you have started on any of these drugs. What do you think some of them will not meet the criteria?
Yeah, that is not that high, sir. Maybe 2 or not more than that. It's mainly the intolerance. Yeah. 1 to 2. It's mainly intolerance which leads to the drug interruptions and not the resistance per se as primary resistance. Because they actually, it's only 1 or 2 in 10, I can say, those for whom we switch over to other TKIs based on resistance pattern. Otherwise, majority of the patients, like 30-40%, they are switched over to other drugs because of intolerance, either because of cytopenias or like effusion with the dasatinib or some like of toxicities which are recurring. So I think resistance is not the main reason, it's the intolerance which is particularly the reason.
Vishnu, do you agree? What's your opinion? Vishnu is there?
No, sir, around 50% resistance, 50% intolerance. Because we generally do not consider mild symptoms as like intolerance. Patient continuing on hemoglobin of 9, 10, we generally supposed to continue same drug. Mild fatigue, we generally do not bother. So in my practice, around 50% because of intolerance and 50% because of resistance.
What Dr. Malhotra think is means with the imatinib, what do you think then? Why the compliance is poor? Is it does the low toxicity contributes to the intolerance? Dr. Malhotra is there? Is Dr. Hemant is there or Upendra? Can you comment?
Sir, with imatinib, most of the time it is the fatigue, pains, anemia, some hemoglobin low. That those are the main complaints, and with these things usually we don't consider for those patients. So these are some vague complaints. So most of the time they are overlooked by the clinician also. So these are the main things that lead to intolerance to these patients. Sometimes, so these patients they have tendency to skip their drug. He says that whenever I don't take my medicine, I feel more
I feel
better.
better.
So he has a tendency to skip these medicines, say out of 30 days, he skip for 5-10 days.
How important is this the 3 months BCR-ABL? So I think below 60 year majority of the people want to discontinue the treatment. I mean, above 60 years because of toxicity profile, we can say the imatinib and you can continue the TFR may not be the goal. But how much importance you do give it to the majority? I mean, you may disagree with me, but would like to discontinue if it is the option. And do you give importance to the BCR-ABL at 3 months?
Yes, sir. So BCR-ABL
Sir,
at 3 months.
absolutely. I think early response assessment is a very, very important aspect of planning treatment. I think for younger patients to keep them motivated that they should take the drug without fail is, I think treatment-free remission is a very attractive goal for, especially for younger people, for whom to accept that they have to take a drug lifelong. I think sometimes that's associated with some psychological burden. And if my patient does not, especially if I'm starting on imatinib and at 3 months I'm seeing that the response is suboptimal, I do switch immediately to a higher second generation TKI.
Sorry.
So I would very seriously wish to disagree with that. One report at 3 months of a BCR-ABL of 12%, which by definition is suboptimal. I would certainly not switch either the first generation TKI or the second generation TKI. So in my book, early response is the assessment at 6 months. Over.
Yeah, I didn't know if it is a 12%, but if it is a 40%,
It's a 26% or something, then I would switch. 12%, and if the kinetics is good, if the decline is good, I would
think
probably
that
continue the same for 3 months
if
more.
you look for kinetics more rather
Yes,
than
yes.
just 10% or 12%.
Yeah, so we are in the process of finalizing the ELN guidelines. The document is ready. You should see the final publication in a month or two. And this has been a really contentious point. 3 months, which are not, but most of the experts internationally agree that you have to have at least one more BCR-ABL report 1 month apart, or at 6 months, pointing in the same direction before you kind of switch too early. Over.
Okay, but means not the switching, but if you don't achieve a goal, that the chances of TFR will be different if you don't mean. I'm not talking about the switching. I'm talking about the goal of TFR. So the previous slide is showing you the chances of going for the DMR, MR4 are lesser if your percentage. Somewhere you have to put a cutoff. So it may not be the 10 and 12, but if you're 26 and 1%, then makes a difference.
Sir, but if you are already started on second generation TKI, then I don't think 3 months will make any difference, because from dasatinib we are not going to change to nilotinib or bosutinib. That will be
We are not,
even
here
the.
we are not talking of switching. Here we are talking of chances of achieving a deep molecular response at certain time points. So you will achieve slowly. If you see a data,
But again, sir, that will not affect the overall or progression-free survival. That's just
you need to be on the drug for longer term. Okay.
Yeah, that may be there. Yeah.
Do you think that treatment cycling, say you are not worried, so give imatinib, and then if the patient doesn't respond, go to the dasatinib, some side effects, go to the nilotinib, versus someone has been started on A drug and continued on the A drug, maybe the resistance or intolerance would have changed the drug. What do you think, Vishnu? Is Vishnu
Sorry,
there?
sir. Yes, sir. So if someone is on dasatinib and like he failed to achieve the desired response like less than 10%, so I would probably continue on dasatinib same, because it is not advisable to change one second generation to second generation based on 3 months BCR EPL. So probably, as Malhotra sir said, I would repeat BCR EBL probably after 1 month if kinetics is not so good, or at 6 months, and then we'll decide based on the subsequent report.
Here we are talking, say, some region because of the intolerance or because of the not achieving a response. May not be 3 months, it's a 6 months or 12 months. And then changing to the A to B drug and B to C drug versus one person who is consistently on the one drug, the cycling because of the various intolerance or this thing. Will that affect the... I think you are using the same mechanisms. Probably that may affect your outcomes. I mean,
So
that's
intolerance will definitely change the outcome, sir. If someone is intolerant to dasatinib, say for example, because of pleural effusion, will definitely change to next drug. Maybe we can go back to imatinib also. So it will definitely affect your overall outcomes. For example, cytopenias are very common with dasatinib. So we need to either de-escalate the dose to 70 milligram or 50 milligram, or we need to change the drug to nilotinib or imatinib.
This is a patient, I mean, more likely if you change from A to B drug or C drug or the same mechanisms, that higher likely to have a mutations and higher likely to have this T315I mutation. And if you develop that mutation, the survival significantly goes down. So this slide suggests that.
Yes, sir.
Does that side effect profile impacts outcome in the CML patient, or someone doesn't have a side effect, someone has many side effects? Does it affect the outcome? Nivedita.
Sir, absolutely. Side effects does impact outcomes, because I think if, first of all, of course, we have to be objective and see how severe the side effects are, but it does tend to lead to therapy interruptions, which then starting at lower doses, suboptimal doses, maybe in some cases, and that I think eventually leads to the emergence of resistance, and it does impact outcomes. There is failure to achieve milestones, so, and a tendency to switch. So I think all of that does impact outcomes, and like you mentioned, even emergent, which we see in clinical practice also, that for patients who had cycling, T315 is something that we do encounter.
Sanjeev?
Yeah, sir. I also do not prefer to switch on from one to second, like from dasatinib to bosutinib or nilotinib, because that's definitely going to uh, create problems. And regarding, yeah, the more the frequent side effects, that's going to impact the overall long-term patients, like their acceptance to the drug. So that's why actually my preference is to start with dasatinib, which I have not seen that much reactions. Probably pleural fusion, I have seen hardly 3 or 4 in my 10 years, or for more than that of.
But there are many other side effects too. So the pancytopenia
The
is a
pancytopenias are
a
for that
significant side effect.
actually.
Even diarrhea and bleeding is one of the major side effects, which we tend, which if you read, may not be coming to the top severe ones. But they're frequent and.
It's a chronic diarrhea we do see frequently. We have patients.
So, if you see a patient who is on 100 and versus 50, you will clearly see a difference.
That's why we
I
have
didn't realize earlier when we were pushing the patient for 100, but when we reduced to 50, then if you have two patients side by side, that tells you the side effects.
So that's we have the option of now giving 50 mg. So if the patient is not tolerating 100, you can safely go with 50 mg.
So this is showing you the intolerance is the primary reason for treatment discontinuation with the various trials. So the significant numbers discontinue because of the intolerance. It's not the only efficacy, and so this is intolerance resulting into the non-adherence. Where do you fit asciminib? Say, so you have failed A and B, then what? So you have used the first generation and second generation, or one second generation, the second generation, then you come to the third line. Where do you fit in? What do you think about asciminib, especially after 2 lines? Vishnu?
So definitely after 2 lines, someone failed on imatinib and dasatinib, I would like to go for asciminib rather than going from dasatinib to nilotinib or dasatinib to bosutinib. So 2+ line definitely asciminib if patient is affordable and there is no availability issue.
You are not going for bosutinib. I mean, say you have
No,
a
sir.
imatinib, dasatinib.
After one second generation, yes, sir. After one second generation TKI, I would like to go for asciminib rather than going from 2G TKI to second 2G TKI.
Sanjeev?
So not even in third
Now we
line.
have it available here, and we have for
Yeah.
quite some time.
In
And
2+
everyone
2+
is
setting, sir.
everyone is
2+ line.
experienced with the drug. So I'm honest answer. I'm asking, what do you do when you fail A and B?
Yeah, sir. Definitely, we have this asciminib option, and definitely for 3-line failure, there is no other option.
No, keep the finances one side.
Yeah.
Someone doesn't have money, you have no choice.
Yeah. No, definitely. So that's what I'm saying. We have options. So asciminib should be preferred, and not even third line. It should be used even in second line. If patient is not tolerating dasatinib, then than going to, if you have used it as a first line, then rather than going to nilotinib or bosutinib, asciminib should be the second choice after dasatinib.
How is your experience as a second line? I mean, how many you would have given it, and what do you think?
As of now, I have used it in 3-4 patients as third line only because it has recently become available. But those who are getting it as a third line, they are tolerating it well. Mild cytopenias I have seen, but not otherwise any major side effect.
What about efficacy?
So too early to say efficacy because hardly 4-5 months started. But I hope as for the literature says,
Any second
definitely.
line, next 1 or 2 patients?
Any, sir?
Second line. So you have failed, say, second generation at upfront, and then you go to asciminib, and what's your?
No, I will go, but I have not had
haven't
that
started
till
yet.
now. Yeah, but
Nivedita?
definitely, if I have the choice, I will go.
Sir, I have used in one patient who had T315I mutation. She had suboptimal response to imatinib, then she had severe cytopenias to dasatinib, and then her BCR-ABL started rising on a lower dose of dasatinib. She had T315I. Now it's been a year of using asciminib for her. We had done the HLA typing. Her sister was a match, but she was pregnant at the time, and luckily asciminib became available to us. So now it's been a year. She's had a major molecular response. Earlier, she was sitting outside my OPD every third day. Now I haven't seen her for 3 months, I think. So, but the one patient that I've used with T315I, it's been well tolerated and very efficacious as
What
well.
dose you are using in T315I?
The 200 milligrams twice a day. It was a panel patient.
Very
so
important, the dose. So if you are going for this mutation, the dose is different versus the if you look at this. Vishnu, your experience with asciminib.
Sir, even with 200 milligram BD, the tolerability is excellent, sir.
Yes.
So it is.
I think
like
everyone
as
will
imatinib.
the side effect intolerability is lesser than any of the other TKIs. That's my opinion.
And in terms of response, also it is a wonderful molecule. So I have used in 5 patients. All patients achieve deep molecular response, and it's been more than a year now.
This,
so it is a wonderful.
You have used in
Yes.
all the 5 patients third line or first line or second line?
One patient third line, sir, and 4 patient T315I.
So, I mean, in both the situations you have used in, and you have a good experience.
Yes,
Dr. Hemant, your final word on this.
Thank you, Dinesh, for the honor. So I would not use asciminib in any patient, newly diagnosed patient of CML because of I call it the obnoxious cost. Now, when would I use
Keep the cost aside.
Yeah, when would I use it? I would use it. Even for a panel patient, I would not use in the first line, newly diagnosed patient, 0 patients. When would I use? Number 1, for the T315I mutated patients. And number 2, for the patient who is not responding, suboptimal molecular response or molecular relapse after 3 second-generation TKIs. So I try all the 3 second-generation TKIs sequentially before
I think that's the
asciminib.
cost is making your decisions. Am I right? The dog is driving your decisions.
Yeah.
But if the cost is definitely the panel is not a panel money is also our money. So take it as our money.
That's right, panel. We have to get this. We have to get our young hematologists and oncologists to understand that if you have too many patients on asciminib or any other horrendously expensive molecule, then you are contributing that much less to nation building. Utti kam road banengi, utti kam flyover
We have
that has
100
to be
rupees and
realized.
we have to use it wisely. So if you give it to the one patient, you will not have for the other people. So obviously you're
And
benefiting one patient.
one more point I'd like to highlight the resistance of our very learned panel to switching from one second generation TKI to the other. If there is switch because of intolerance, then you must try the next one and the next one. And if there is suboptimal response or molecular relapse, there is still a 5 to 10% chance that the next second generation might respond. So you may wish to consider that, not completely not consider that. Over.
If it is because of intolerance, definitely the other one will work.
Yes.
If not, the efficacy has impacted your decision. What is the, so we are short of time, so otherwise there's a good discussion going on. This is Bosutinib versus him. So we have assembled trial which clearly have showed versus at the various time points the cumulative incidence of MR by 24, 96 and 156 was better than Bosutinib. So when you compare it with Bosutinib as a third line, definitely this has efficacy outcomes better. I'm not going to the details, but progression-free survival also was, but the PFS and the overall survival. What is the safety profile which affects the quality of life? I think that matters a lot. Someone who has tried a 1, 2, or 3 lines, and then you put it to the very toxic kind of a drug, the tolerance will. People who are not tolerating A may not be tolerating the third line with the. So there is the good part of the asciminib is the major side effect is the cost. The rest of the complications are less. The lucrative it looks as a combination which has not yet come. So whether you can use both the mechanisms together, and this is a quality of life. So definitely Bosutinib versus asciminib, all the points have been better into the. I think what is the response to the asciminib? This is the response service for this. I'm not going to the depth of this because we are short of time, but we had a good discussion, I think. Anything more you want to add, Sanjeev, regarding the asciminib and as a third line, or anything you want to add on this?
No, I would like to say only that our at present first line, my choice is a second generation TKI, either Dasatinib or Nilotinib, and if patient progresses or fail on these, then go to Asciminib.
So may I ask one question?
Yeah.
That where do you place, like in my patient, we did the HLA typing and we wanted to take her up for a transplant. At that point, her donor was pregnant. So where do you place transplant with the availability of asciminib? Because a transplant will be more cost effective in the long run. So where do you place transplant?
That's what we did.
This is your this mutation is in, you are still in a chronic phase. So
yes.
You can try the few drugs which are working. So if you're achieving a MMR, you won't go for the goal is to achieve a MMR. So if you're achieving a MMR, probably no transplant, provided the cost is a major hurdle. So the transplant used to be the costliest hematological procedure, has become one of the cost-effective treatment. So I think the cost will drive you towards a transplant. Otherwise, if you're achieving a MMR,
yes,
Dr. Hemant, you want to comment? Nivedita is asking you about the continuing on asciminib versus allogenic transplant.
So, Dr. Dinesh, sir, you have last 2 minutes to conclude.
Yeah, so I'm on the last slides. Dr. Hemant is not there.
That's great.
Yeah, no, I'm very much here. So
Okay,
Dinesh, my response would be that if the patient achieves a major molecular response on an oral drug, which is well tolerated, I would continue that. You still have lots of toxicities of allogenic transplant. You have a 10% 100-day mortality, 5 to 10%, maybe much less with your center, but still most centers 5 to 10 100-day mortality. And if the patient is unfortunate enough to get GVHT, then his life is really hell. So I would continue asciminib till there is molecular response. I would not use it as a bridge to transplant. Transplant would be my next line of treatment. Over.
But if you achieve a suboptimal response or inadequate response, then the transplant should be.
Yes, then the transplant will come in, definitely, no question. But it will be the fourth line, and asciminib will not be my bridge to transplant.
And for T315I also, sir? Like
Yes, that's
Yeah,
semaglutide
for
rule
that's right.
is
For
same.
D315I also, if the patient has a deep molecular response, I would continue the oral drug, which is well tolerated, hardly any side effects, rather than risk the toxicity, permanent and temporary, of a transplant. Over.
I would like to read this slide before Tarun comes in. Assemble is the first randomized phase 3 trial using a 2G TKI as a comparator, as more than TKIs, more than 2 TKIs. After 3.7 years of follow-up, Assemble continues to demonstrate superior efficacy and better safety and tolerability than bosutinib. Within 24 weeks of treatment, patient receiving Assemble showed an improvement in the symptoms and the quality of life related to the bosutinib, and responses continue to deepen over the time. And patients who continue asciminib treatment beyond week 24 continue to drive benefit. With this, I'll stop. I'll thank Dr. Hemant Malhotra. I'll thank Dr. Jasuja, and I thank my panelists to be patient with us. Thank you.
Thank you, sir. Thank you. And for Nivedita's case, sir, I will go with transplant. Thank you.
Thank you, sir.
Thank you. Thank you.
Next panel
Okay,
discussion.
okay,
We'll leave it to the
okay.
next panel discussion.
So for the next talk, I would like to invite Dr. Prakash Singh Shekhawat. He is my dear friend, working at Bhagwan Mahavir Cancer Hospital as a consultant hematologist and hemato-oncologist and bone marrow transplant physician. He will be talking about evolving treatment and their clinical implications for DLBCL patients in India. Over to Dr. Prakash.
Thank you, sir. Thank you for the kind introduction, and it was very beautiful listening to all the experts for this CML talk. So am I audible?
Yes.
And is the screen visible, sir?
Just show the slideshow. That's fine.
So I will be speaking on DLBCL and the recent treatment which has evolved. And this is the disclaimer. This is sponsored by Ross, and these are the disclaimer they want me to explain. So what is the DLBCL used to be our one of favorite, it's like myeloma. The most patients will have some improvement. Ultimately now with longer follow-up, we are realizing that most patients don't get cured, and it's almost 60 to 65% gets cured. Frontline 15% resistant, out of the 85, again 20-30% will relapse. So ultimately 30 to 45% patients are refractory or they relapse, and they need a second line treatment. If the relapse is within 1 year of the initial therapy, we consider it as a chemorefractory and we need to go for a CAR T-cell therapy. Otherwise, salvage followed by high dose chemotherapy and ASCT. Still, some gets cured, some doesn't get cured, and the disease ultimately progresses, and we don't have much of option beyond third, fourth line in case of DLBCL. So 60-65% gets cured, rest don't get cured. And for the last 20 years, during my training, I have not seen CHOP for a DLBCL. It's almost always R-CHOP. And we know that rituximab has done remarkably well. It has improved the PFS. It has significantly improved the quality of life without adding much of toxicity, actually, the toxicity which a chemo would add. So rituximab is a clear winner, and R-CHOP was undisputable king for DLBCL for almost 2 decades. But we still have some unmet needs in DLBCL, especially with R-CHOP, because R-CHOP is good enough for limited stage 1, 2, or with low IPI when the disease is localized, not involving CNS, extranodal site. But when it's very high IPI or an elderly where we think the drug will cause a lot of toxicity or a ABC type of phenotype, double hit, double exposure, then R-CHOP has its reservations. And ultimately low curability for those cases of DLBCL. And many things have been tried. Some have worked, some have not worked. But mostly, if you see, if we are changing a CD20 Gazyva instead of rituximab, it doesn't work. If we are adding some new molecules, we can't give the molecular typing of cell of origin. And most of the drugs like Ibru, Len, bevacizumab, bortezomib, adding these have not done a good job to the conventional R-CHOP. And dose adjusted epoch is one thing which has worked, but for a limited group of patients. But for most, the R-CHOP still stands, and we are left with not much of choice. So most of them have failed. And we need to improve the outcome. So there comes a new molecule, which is polatuzumab and anti-CD79B. And polatuzumab, along with R-CHP, This is the only regimen in last 2 decades which has shown improvement over rituximab, and it has been tested in first-line setting also. Approved in 2022, the European Commission, and 2023, FDA have also approved pola-R-CHP as first line for DLBC. So what we see that the Polaric study, it was a phase 3 double-blind randomized controlled trial, and almost 880 patients were included. Adult population 18 to 80 with good performance status and advanced IPI. So IPI 2, 3, 4, 5 was done. And it was 1:1 randomization with 6 cycles of pola-R-CHP versus 6 cycles of R-CHOP. And they were given 2 more cycles of rituximab maintenance in both the arms. So what the investigators have shown, the primary endpoint was PFS and secondary endpoint was OS, TFS, EFS, and PET-CR at the end of treatment. And the primary analysis close to approximately 28 months have shown that those who have received polar group have a significantly better PFS compared to a rituximab R-CHOP group. But there was no difference in OS, and OS was almost comparable in both the group. So polatuzumab have achieved its primary endpoint of prolonging the PFS. And by prolonging the PFS, the risk of relapse and subsequent therapies and death was significantly reduced. So less patients were dying and relapsing. So the investigator assessed PFS was with multiple subgroups like cell of origin, age, double expressor, previous therapies, kind of these things, and so not previous, the later line therapies. So if we see that the polatuzumab didn't have much of a significant difference in the GCB arm, but when it comes to the non-GCB arm, ABC arm, we can see that Pola has clearly won, and there is significant difference in the PFS of non-GCB arm and polatuzumab. And when we take it in a complete DLBCL without a subgroup analysis, we don't have a statistically significant number, but this curve is good enough to tell all of us that the ABC polatuzumab, no doubt. When we are doing for double expressor, BCL2 and MYC expression, we can see that in double expressor lymphoma, both R-CHOP and polatuzumab have been tried. And this subgroup have shown that double expressor lymphomas, polatuzumab has done better compared to R-CHOP. And in them also, the non-double expressor and double expressor non has done better, but Pola has done better, and the risk which is given with a double expressor is also mitigated by polatuzumab. If we see the extranodal sites, then also the upper curve, we can see on the first left side, the orange color is pola-R-CHP and blue is R-CHOP. So polatuzumab has given a statistically significant PFS advantage in those patients with extranodal involvement also. The hazard ratio was 0.72 with a confidence interval 0.5 to 9.6. If it was tested in elderly subgroup, this is the subgroup which we are more concerned, because many patients in us come to our clinic with a bracket of 70 to 80. We are not giving them full R-CHOP. We hesitate with our mini CHOP, R-CHOP B. And in this subgroup, they have shown that if they are replacing polatuzumab instead of infestin, the pola-R-CHP has shown better PFS in the elderly, although no OS benefit, but the PFS benefit is there in this bracket also, and especially with a high IPI of 3 to 5. And the super senior citizen, more than 80, where we dare to treat them. We treat them with rituximab and 1 chemo or 2 with a very half doses. In these population also, the pola-R-CHP was found to be better, and the complete response rate was almost 64%. And the best thing is that many patients were able to take treatment for 6 cycles. Most of our patients in more than 80, they won't be able to tolerate 6 cycles. Second, third cycle, then because of toxicity, we need to cut it down or call it a day. No more treatment. But here the patients are taking treatments, and the median age was 81 years, and it has achieved its goal of primary endpoint of 6-month PFS. Almost 85% patient have done this. What if we are including this with R-CHOP in high-risk DLBCL patients, where high-risk DLBCL patient although we are not using R-CHOIP, but it was a retrospective study where they have included for age-adjusted IPI of 2 to 3, and the first line Pola-R-CHIP versus R-CHOIP from another study, Pola-R-CHIP from Polaric study. Although not voiced to compare two different studies across two different a time point, but there was no difference. Means Pola-R-CHIP has done equally well compared to R-CHOIP of the for these young patients, those who can tolerate the added drug. And OS is showing a favorable trends toward Pola-R-CHIP, although not curves are not different. And if we take it for the IPI 3 patients, initially that was for 2, 3, but if we take only IPI 3, the more higher risk patients, then we can see the Pola-R-CHIP is even better compared to R-CHOIP patients, both in terms of OS and in terms of PFS. For OS in this category of young high-risk patients with IPI of 3, the overall survival is significantly better, and we can see a 23% difference in OS at 2-year endpoint, which is a big number. What about the side effect? The side effect which we normally see, the cytopenias, infections, they are more with R-CHOIP because we are adding one more chemotherapy, the etoposide, which itself is notorious. And when Christine etoposide ultimately causes more sensory neuropathy. So the risk of cytopenias, infections, and neuropathy was greater with R-CHOIP compared to Pola-R-CHIP in this population. We see leukopenia 5% versus 35%. So neutropenia is significant. Febrile neutropenia is also high, almost double. And we see more than grade 3 thrombocytopenia, almost 2% in Pola-CHIP. And it's in R-CHOIP, it's almost 20%. So significant difference in OS at the end of 2 years, significant difference in toxicity profile also. So the Polaric study, we have seen data at the end of 28, 29 months, but the study was continued and the long-term data after follow-up of 5 years are also out, and the long-term follow-up also confirms the initial trend. It's like the election day, now we see the election trend by 10 a.m., the result continues same. So PFS benefit, which was seen at the end of 28, 29 months, 2.5 years, is still maintained at the end of 5 years. And we can see a significant PFS difference in Pola-R-CHIP with a hazard ratio of 0.73. And when we see DFS, DFS is also better in this arm when we are following these patients for a longer period. There was no OS difference initially, there is no OS difference still at the end, although OS is favoring this, but it's not statistically significant. The primary endpoint was PFS. It is meeting its primary endpoint. It is maintaining its primary endpoint even at the end of 5 years. And many patients have died, almost comparable in both the arms, 50-55%, because of multiple things. The progressive disease is an important part. 9% in Pola-R-CHIP have progressed with this 5-year follow-up, and 11% in R-CHOP arm have progressed with this 5-year follow-up. Rest all are slightly less in Pola-R-CHIP. What if we are treating those patients upfront? What is their chances of getting relapse and then requiring a second-line therapy? We see that almost 61 patients in rituximab CHOP arm, the blue one, they required a second-line therapy versus a 38% in Pola-R-CHIP. And the second-line therapy, it consisted of radiotherapy, another salvage or a CAR-T or a stem cell transplant. With polatuzumab upfront use, we have seen that the chances of second line, third line, or even the later line therapies are still less in this compared to rituximab CHOP arm. And 5-year DFS OS outcome, we have seen some important subgroups like ABC versus GCB, then the elderly one, then the in our mega CHOIP arm. So we can see that if the patient is having double expressor or extra nodal, or if the subject is GCB, then the chances of PFS better in polatuzumab arm is good. We see with a higher IPI of 3 to 5, the Pola has done better. Then if it's a bulky disease, the PFS HR is 0.61. It is significantly better. If it's a high-grade B cell double hit, triple hit lymphoma, it's better, but not statistically significant. For DLBCL high grade, it's good. Then nanostring cell of origin, it is favoring. Double expressor also we see it is favoring. There was no significant difference in OS. And safety wise, any grade toxicity is almost comparable in both. But if you see grade 3 or 4 adverse event or grade 5 or serious adverse events, they are less in polatuzumab arm compared to R-CHOP arm. And safety profile, it has consistently remained almost comparable, not worse, slightly better, even with a long-term follow-up of 5 years.
So, Dr.
And
Pratap, sir, a brilliant presentation. I think if you can conclude, please.
yes, 2 minutes more. And there are some serious adverse events like neuropathy and cardiac arrhythmia. They all are relatively less in compared to R-CHOP arm. So we can see that all toxicities of interest are less in pola R-CHOP arm. And the main conclusion with this is that with the extended long-term follow-up of 5 years, we see that it is beating R-CHOP, especially in terms of PFS and DFS, no OS benefit, and there are fewer side effects and fewer second, third line treatment needed with polatuzumab arm. This favorable outcome, especially in extranodal and ABC arm, and the safety profile is as good as a R-CHOP arm. And 5 year data confirms that pola-R-CHP is now the standard of care for first line DLBCL, especially if it's a ABC type first line, and thus it has been FDA approved and it has shown a significant result. So this has been R-CHOP. Polarix is the first positive phase 3 study against R-CHOP in last 2 decades, and long-term analysis we have seen it is favoring pola-R-CHP in terms of PFS, and OS is also better. Patient required less subsequent therapies, almost 27% less patient died. So we need to do what patient needs next. So that's the time when we can bring forward our new therapy. And I think at least for a select group, this should be offered. Thank you.
Thank you, Dr. Prakash, for that excellent talk on how we can use polatuzumab upfront in our DLBCL patients. So you enlightened us the use of polatuzumab. Yes, really, that for long years there was not much of difference within R-CHOP with any of the, as you have explained in your trials in your slides. So use of polatuzumab has significantly improved in the PFS in most of these patients with the reduction of the death of these patients. So now
Yes.
we will move to our last presentation by Dr. Dinesh Gurani sir. He is working as the head of department at and bone marrow transplant physician at RGCI Delhi. So we will be talking about management of relapsed refractory multiple myeloma. Over to Dinesh Gurani sir.
Evening. How is the Josh?
Sir, full Josh.
My slides are visible?
Yes, sir.
We're going to talk. I'll take a 10 minutes. So Tarun, you can stop me whenever you think. So I can go to my conclusion slide and we'll leave it. Relapsed refractory myelomas. There are many options available. We used to had only chemotherapy. Now we have a CAR T. CAR T is coming to our country too. What I'm trying to draw the attention is that the chemotherapy part has gone from 2015 till now. You see a monoclonal antibodies, you see a bispecific antibodies, you see a drug conjugates, you see a CAR T, no chemo or no other therapies. What does it mean? The treatment is going to be costly. They are going to be more effective. They're going to show you that this is more effective. At the same time, is going to be beyond our this thing. The drugs are coming to front line. Someday you will see a CAR T up front. So everything is from the 2015 onwards. The daratumab is already up front. Many people are paying for it. Is recommended. So similarly, the other things. So the myeloma is, if you see from 2015, there is no new chemical or new other things. More is immunotherapy and immunotherapy. So previously there was if you go for relapsed refractory, whether you are a botensilimab refractory or you are a lenalidomide refractory, there is a new group is anti-CD38 refractory now, because this has been approved in the upfront for transplant eligible and transplant non-eligible. There's another important thing is after one prior line of therapy, including IMiDs and PI, and if you are refractory to lenalidomide, category 1 is a cilta-cel. So if you are failed a one line and refractory to lenalidomide, good luck. You need to go for cilta-cel. And similarly, if you have 2 lines. So the recent data, there'll be some data to show you. This may be upfront also for high risk. So this is a recent changes into the NCCN guidelines. If you go to the previous 2 or 3 lines, then you have many things, many bispecific antibodies. If you have failed a CAR T, then there is a bispecific. Many of the bispecific have been tried upfront alone or along with the approved drugs. So sooner the bispecifics also will be part of the upfront therapy. That is changing the course. So sooner we'll see the more effective therapies, but at the high cost. These are Mayo Clinic recent ones. First relapse, not refractory to lenalidomide. You have a DRD, and if you are refractory to anti-CD38, then PI with RD. So different combinations have been tried. And if you are refractory to lenalidomide and not refractory to DARA, then definitely the DARA becomes upfront along with the second generation PI or second generation immune modulators. Second and later, if you see a second or later relapse, CART, you may have some options, or bispecifics. These are the options. So there are not many options if you are a second or third line refractory. If you are refractory to IMiDs or bortezomib, alkylators, anti-CD38 and BCMA, then not many options are left. So these are the guidelines, NCCN guideline and AMISPART guideline. What the people have done for the second, if you are refractory to lenalidomide or bortezomib, they have tried 3 drugs versus 2 drugs. So for the approval from FDA or European Union, they smartly, we know the more drugs are so far in myeloma, the 4 drugs are better than 3 drugs, 3 drugs are better than 2 drugs. So all the approvals trial, they have tried combinations with the 2 drugs. So definitely the 3 drugs are better. That's how they have got approval into the relapse and refractory, whether it is a pomalidomide, whether it is a carfilzomib, or whether it is a daratumab. All the drugs have been approved based on the 3 drugs versus 2 drugs in the relapse and refractory setting. This is a similar kind of graphs which shows the 2 things which are important. One is a blintamab, which is a drug conjugate, and CAR-T and bispecific. So these are the 3 things which are which have been approved in the relapse refractory setting. Dream 8, if we are aware, the blintamab was tried upfront and didn't show much response as a single drug, and had a higher toxicity in the larger amounts. So they have gone to the the slower doses and with the combinations. So this is a Dream 8 trial. So this drug is sooner going to come back, was withdrawn from the market, is sooner going to come back. This one shows you the BPD, blintamab, pomalidomide, dexamethasone versus pomalidomide, bortezomib, and dexamethasone. There is a significant difference in the 12 months progression-free survival. So this is definitely better than pomalidomide combination with bortezomib. Similarly, the Dream 7, it shows you, this is the 3 drugs versus 3 drugs. Previously, all the combinations were 3 drugs versus 2 drugs. And here also, it shows you if you have the same combination, if you are using the bortezomib dexamethasone in both the arms, blintamab is better than daratumab. So definitely this has a conclusion that blintamab is a good drug and probably is better than daratumab. So if you're using some combinations, if the drug is available, unfortunately this drug is not available. So these 2 trials are going to bring back this drug, the conjugate, BCMA drug conjugate to the back. This shows you that if you're DARA sensitive, lenalidomide refractory, these are the possibilities. If you are a bortezomib refractory, these are the possibilities. If you are a lenalidomide, so 3 drugs. Now, if you see all these are 3 drugs except the CAR-T. And if you are sensitive to both the drugs, lenalidomide and bortezomib, you can still use both the drugs if you are sensitive. There are definitions of sensitive versus refractory to a drug. Similarly, if you are refractory to DARA, then you look for a lenalidomide refractoriness, botulism. So I like this way of presentation because if you're A sensitive or A refractory, then B sensitive or B refractory, and then you choose the combinations. Choose a 3 drugs versus on not many will be on the 2 drugs. The frail patients is a totally different ball game. Frail patient, the safety is important. The 2 drugs also are enough. So except the frail patients, the 3 drug combination for the relapse setting, not the 2 drug combination. The CAR-T is coming to the front line, to the at least a first relapse. This is a KarMMa-3 trial. This is after the 2 lines of, this is a ide-cel versus standard of care. So the comparator arm is not the 2 drugs. Comparator arm is anything which is a standard of care at the time of comparison. That shows a significant difference into the, mainly the stringent CR. So this has a, this has been approved for second line. If you see a median progression-free survival also is significant. CAR-T4 cilta-cel after a 1 line of therapy shows a significant difference in comparison to the standard of care. So they are definitely better in the relapse setting in comparison to, because if you see a standard of care, the median progression-free survival is lesser. If you go to this one, the median progression-free survival is 6 months, the standard of care. So that after the two lines. Here also, if you go for the median progression-free survival is much lesser with the standard of care. So unfortunately, after the 1 line or the 2 lines, if you are especially lenalidomide refractory, the outcomes are, the duration of the response is not great. Acute toxicities and the management of the acute toxicities with the CAR-T cell therapies. I have experience of using BCMA CAR as a part of a trial from Reddy's group. It looks good, means it's effective. How long I need to wait for the data is very only 2 patients. Similarly, there are delayed toxicity. The cytopenia is a major problem with the BCMA CAR. And every CAR is different. So you cannot compare the ide-cel with the cilta-cel or versus our Reddy cell. So with this, the data with approved CAR-T cell therapies, this is a phase 3 KarMMa-3 and CARTitude. The number of patients, triple class refractory, there were significant numbers in the 60 in the ide-cel versus CARTitude. So they are 2 different. You cannot compare these 2 together. CRS level is significant. Neurotoxicity is a major problem with the cilta-cel, but the responses are reasonably good. There are many bispecifics have been approved in the relapse setting. Teclistamab is available in India, so we should talk about the teclistamab, elranatab, talquetamab. Now there is a combination of teclistamab and talquetamab. Imagine if you have to use a 2 bispecific for long term, how much will be the cost? We have used, many of us would have used teclistamab as a part of trials and once commercial launch. There are approved for 4th line or 5th line. They are going to be sooner approved for the earlier lines. Median duration of response. So I have taken a teclistamab in the relapsed refractory myeloma. Overall response is 63%. Stringent CR is 38.8%. With the bispecific, the infection is a major problem. In our country, if you're going to use a teclistamab, give a Bactrim, give a posaconazole, and watch for the bacterial infection, monitor the IgG levels and give IVIG, vaccinate for flu, and so the preventing the infections, treating the infection is more relevant in our country with the bispecific antibodies. They are effective, but they have the infections, and especially we have multi-drug resistant bugs is very important. This is a teclistamab. If you see overall response, CR and VGPR looks reasonably good in the fourth or more lines of therapy. This is I showed you that the teclistamab with teclistamab. So there are combinations also are coming up. Sometimes you use a bispecific as a bridging therapy for the CAR-T cells. If you have both the options, the CAR-T cell should be used front. Then keep the bispecific for the later lines of therapy because the one-shot treatment. But there is a data if someone is exposed to the bispecific, then do a CAR-T. Someone is exposed to the CAR-T, then you do it. And then we have a different targets also. safety of the approved teclistamab, talquetamab, and elranatab. So these are the toxicities. The CRS and ICANS are lesser, but the infections are definitely a significant concerns with the bispecific antibodies. The drug conjugates, we don't have it. CAR T cell is going to be soon approved. Bispecifics are here, very costly. And so I think my transplant is cheaper than all these therapies. So transplant is one relevant. If you're not being transplanted upfront, use the transplant, the second line. If you're not been exposed to the DARA, if you have a money, use the DARA as a second line rather than seventh line. That would the message, at least I would like to give it. These are the factors to consider, what to choose it. There are many factors have been given. I think we have to make our local factors to what to consider when everything is available. With this, I'll stop. Thank you.
Thank you, Dr. Dinesh Burani, sir, for that excellent talk on relapsed refractory multiple myeloma. So you enlightened us on the role of BCMA, CAR T cell therapy, role of antibody, the conjugate bendamustine by DREAM7 trial, showing superiority of BVD versus DARA VD. Because most of them we say DARA is very superior drug. So, but showing superiority of DARA VD with as compared to bendamustine VD. It is not that much of favor drug bendamustine, but with DREAM7 trial, it has shown superiority of with as compared to DARA VD. And you have also enlightened us on the role of CAR T cell therapy with CARTITUDE-4 and KARMA trial with ID cell and CETA cell and use of bispecific antibodies, BCMA, CD3 target talquetamab, talquetamab. So very good informative talk. Thank you, sir. Or to organizers for the
Thank you, Dr. Dinesh Burani, sir. Thank you, Dr. Pedna Sharma, sir, for managing well. So we can see the smile with Dr. Sandeep Jasuja, sir, with such a brilliant discussion. Dr. Jasuja, sir, over to you for their final word, and then we close.
Thank you, Dr. Jasuja, for inviting us, for giving us an opportunity.
Sir, thank you very much. You are my mentor and you are my really teacher also. And really, it was a great lecture and deliver what you have did always. And really, I enjoyed a lot from your lectures also, sir. So, our dear delegate, esteemed faculties and guests, as we draw the curtains on the Precision Oncology Unplugged over the past 2 days, we have witnessed a confluence of knowledge, innovation, and collaboration. A truly remarkable academic journey throughout the evolving landscape of the precision oncology. Today's session brought a sharp focus to GI, GU, and hematological cancer, especially. I thanks to Hemant Malhotra sir and Dinesh Burani and Prakash for giving excellent talks and highlighting how the molecular advanced immunotherapy and personalized approaches are reshaping outcome for our patients. From ASCO update by birth to the real world practice strategy, our discussions are not only evidence based but deeply inspiring. I extend my sincere thanks to each one of you, our speakers, moderators, panelists, chairperson, and attendees for your time, insights, and dedication to improving cancer care. Your contribution made this event not just a conference but also collaborative mission, sir. A special note to appreciation to our organizing team, especially thanks to Mr. Tarun and team, our academic partners and institutional leaders like Hemant sir, Dinesh Burani sir, and many more, Atul sir, and also pharma companies to making for this event seamless and impactful. Let us carry forward the spirit of this conference to caution, to innovate, and to heal as we continue to serve our patients with cutting-edge science and compassionate care. Wishing you all a continued success and strong academic bond until we meet again in IBCC 2025. Again, thank you very much, all of you, and very good evening and good night, sir. Good night to everyone.
So thank you so much, Dr. Jasuja, sir, for this kind words on behalf of my colleagues, Yashika and Vishal, from all of us, from the organizing team. Thank you. Stay safe, stay blessed. Good night. Till we next meet in IBCC 2025. Thank you so much. Good night to everyone.
Good night.